you all to the 71st Foundation Day ceremony of the Department of Pediatrics. It's a very big day for all of us. At the outset, I would request Professor Mala Kumar, our head of department, to accompany the dignitaries to take their places on the dais. Honorable VC Ma'am, Professor Saurabh Datta, Professor B.K. Ojha sir, and I would also request Professor Chandrakanta Ma'am to take her place on the dais.
Dr. Ojha.
I will request Dr. Shalini to welcome the dignitaries on the dais with plants. I'll request Dr. Manisha and Dr. Smriti to welcome our guests for today who have joined us, Dr. Pradeep Tandon, Dr. Sanjay Niranjan, Professor J.D. Rawat sir, Professor Sunil Kumar sir, Professor Kureel sir, Dr. Anand Pandey, Dr. Nitin Pant, Dr. Sunil, Dr. Suresh, Dr. Rashmi Ranjan and Dr. Nirmalya, Dr. Zaigam Abbas, and Harsh Khannaji. So the foundation stone for this department was placed on 14th November 1954 by the then Chief Minister of UP, Shri Govind Vallabh Pantji, and today we are all here to celebrate the 71st Foundation Day of our department. I'm grateful to all of you for taking part in our celebrations. I now request all the dignitaries on the dais to come forward for the lamp lighting. Thank you, everyone. So to plan your future in the best possible way, one needs to revisit and introspect the past. Now is the time to listen to the progress and milestones reached by our department in the last 1 year. I'll call upon our head of department, Professor Mala Kumar, to to welcome the dignitaries and present the department's annual report.
A very warm welcome to everybody who is assembled here today to be part of our 71st Foundation Day. And I request all the dignitaries on the dais to please take their seats in the hall so that you can all enjoy seeing our report, our annual report. I'm sorry for the exercise up and down the stairs. A very, very warm, special welcome to our Vice Chancellor, Professor Sonia Nityanand, who has so graciously taken out time to be with us today. We all admire your progressive vision and constant support for all our endeavors. You always go out of your way to do everything you can for sick children and our department. A very warm welcome. Welcome to our guests, Dr. Saurabh Datta, who's come all the way from PGI Chandigarh and to be with us and who's being awarded one of the orations today. We gather here today to remember two of our very eminent and teachers, Professors N.L. Sharma and Professor P.K. Mishra. They are loved and revered by most of us. Many of us in this hall are their students and cherish them. And we like to celebrate them every year on the Foundation Day. Dr. Saurabh Datta and Dr. Monica Juneja, she was awarded the other oration, but because her mother was not well, so she couldn't join us. She'll join us online. And then we have Dr. Rashmi Ranjan Das from AIMS Bhubaneswar, who's also going to speak to us about pulmonology, bronchiectasis. And Nirmalya, who did his senior residency, Professor Nirmalya, who was a senior resident with us previously and works in the Tata Memorial now. And he's come to be with us today. Thank you very much. I also thank all the other heads of departments who are here with us, Dr. J.D. Rawat, and Dr. Pradeep Tandon, Dr. Vineet Sharma was here, Dr. Kuril, and all the other faculty who are with us today, to be with us. Then Dr. Ojha, who is our CMS, who is so dynamic and who's ready to help us whenever we give him a call 24/7. He's always there. I don't know whether he sleeps with his mobile or what, but he's always available and he always helps us out so happily. Thank you, Dr. Ojha, for coming here. I also welcome all our Dr. Abbas, who's come to be with us, and all our faculty, all our residents, हमारे सारे कर्मचारी, सारी नर्सेज, आप सबका बहुत बहुत अभिनंदन है। तो आज हम सबसे पहले एक एनुअल रिपोर्ट अपनी दिखाने वाले हैं, and I hope you all enjoy it. It's just a glimpse, like a trailer. The movie is long, but we'll see the trailer. I hope I'm visible because the department was established in 1954 and our vision is to be leaders in teaching and training in pediatrics, and our mission to protect and promote health of children by providing quality patient care, training, research and innovation. So this is down memory lane, a picture showing the 10 heads of departments, starting from the beginning, and I'm the 11th. And the oration is for Professor N.L. Sharma and Professor P.K. Mishra. Both of them have been instituted by their families, and we really enjoy celebrating them every year. This is our faculty. We are a faculty of 14. Those who are with the red frame around them are new faculty who have joined us just a few months back. And each of them has some special area of interest. And Dr. S.N. Singh likes to do neonatology, Chandrakanta into neurology, Dr. Yadav into pediatric critical care, Dr. Nishant into hemato-oncology, Shalini mainly into neonatology, Sarika pulmonology, and Sanjeev into gastro, Arpita who does endocrinology, and Vinod nephrology, Arisha into neurology, Neeraj into intensive care, Manisha Verma gastro, and Smriti Jain neonatology and endocrinology. Then we are sad that some of our faculty moved ahead, but they went to greener pasture. We have Dr. Vishal Punia, who is now working in the Department of Nephrology and is missed by all of us for all the help that he used to render to patients with kidney problems. And Dr. Harkirat Kaur, DM in neonatology, who's now moved on to AIMS Jammu. Those are pictures from their farewell parties. Then the programs and courses that are offered in our department, MBBS, MD, we have 24 seats. Currently 24 students enrolled for doing MD in pediatrics. We had 26 seats previously, but now that has been reduced to 24 because of lack of faculty. PhDs, we have 7 current intake for PhDs. We have MBBS electives. You can see people getting their certificates in intensive care electives and neonatology electives. And we have some value-added courses, postgraduates ke liye, for in pediatric advanced life support and neonatal resuscitation. Then we have fellowships, pediatric neurology, oncology, neonatology, pulmonology and intensive care, and gastroenterology. These we are very fortunate to have with the efforts of Professor Sonia Nityanand, who went out of her way to see that all departments had a substantial pool of fellows working with them. Thank you, madam. These are the beautiful fellows. I don't know how they suddenly become beautiful the moment they finish with their MDs, but here they are. Then we have PhDs, currently 7. 2 of them are faculty. Arpita and Shalini, they're also doing their PhDs. Then pictures from the value-added courses, PALS and NRP. Students enjoying posing for pictures with their certificates. Then undergraduate teaching is based on NMC competency-based strategies. Skill-based modules are in place for evening teaching, and small group teachings are there, and standardized OPD teaching modules have been prepared so that there is a certain standard at which the teaching goes and no topics are missed out. And we are really, really proud of our evening teachings that happen. Our traditional evening teachings. When Dr. Sonia Nityanand and I were residents, we used to be there for evening teachings. All of us who are from here, they know how important and how much special attention evening teachers have. And there are a lot of romances and all that come up from those evening teachers. That's another story. Then we have a skills lab, a digital library, our research footprints. So there were 57 publications from our department. Areas of thrust are neonatology, pulmonology, infectious diseases, childhood cancer, and neurology. And the citations ranged up to 995, H index from up to 80. And the impact factor of the journals was up to 13.7. And I feel shy in saying that book chapters were only 2 and no books were written. And Dr. Saurabh was saying he's just written a good book on neonatal sepsis. I will try to follow your steps and write a few books now. So projects, 18 of them are running in the department at the moment. Some of them are sponsored, funded by the ICMR, DHR, DHRMU, ICMR again, you can see quite a few of them, 18 of them in fact. Then departmental distinctiveness. NMC-based curricula for UGs as well as for PGs. Oh, welcome Rashmi ma'am and Archana ma'am, our beloved and revered teachers. Please take your seats here. Thank you for coming. Archana madam and Nirmalya used to work with Dr. Archana Kumar in hemato-oncology, and Rashmi ma'am is the one who helped us all grow and learn a lot of neurology. Thank you for coming, ma'am. So distinctiveness is that it's an NMC-based curriculum that we follow, and there's efficient bedside evening teaching, skills lab are in place with high fidelity mannequins, and we have regular audits, mortality as well as culture audits. We have fixed SOPs for PGs, UGs, and even interns, and there is a system of feedback. Then for the PG students who join in, we have an orientation session because they don't know what they're supposed to do when they come. So they are oriented to the department and the culture, the work culture here. And we try to have the ICUs empowered by the best of our manpower. Now, whatever pool we have of nurses, we try to choose the best and post them in ICUs where their expertise is so much required. Then there is a lot of emphasis on subspecialty development, as you will see as we go on with the presentation. And we have a very, what should I say, a very vigorous state newborn resource center. Dynamic, we just keep doing something or the other all the time there. So what about patient care that happens in our department? So there are 6 units, Monday, Tuesday, Wednesday, Saturday, 6 units. One PICU, neonatal unit, one exclusively for inborn babies, the other one has a mix of inborn and outborn babies, and an oncology unit. And in all, we have 285 beds. And you can see the distribution of beds. PICU, emergency beds are 47, PICU 20. The neonatology unit, together, the inborn and outborn is more than 70. Then children's ward upstairs and downstairs, and the pediatric oncology with 20 beds. So here's the peep into the pediatric emergency, the children upstairs ward in this building, and here we have the PICU and the children downstairs ward. Then this is the NNU, which is the inborn unit of for newborn babies, which is in the Queen Mary's Hospital, where the obs and gynae department is. And that is the NICU, Shalini, Shakal, our residents, all visible there, posing for the picture. Then the oncology ward, Nishant's delight. Dr. Archana Kumar is smiling as she sees this picture, I can see. So it's a happy ward, happy looking, colorful ward. Thalassemia daycare, then we have a library and a play area. Play area also children love to visit. The special facilities are the pediatric bronchoscopy, the pulmonary function test that is managed largely by Sarika, then continuous glucose monitoring, that's part of what Arpita does, then the UG, the upper, what is this? The endoscopy unit, pediatric endoscopy unit run by doctor under the supervision of Sanjeev, and Manisha helps him out with that. Then we have HFO ventilators, pediatric and neonatal. Then this pediatric CAPD and hemodialysis, I didn't want to remove because for more than half the year we were doing this. Now that Vishal is no longer with us, it's shifted to another thing, but the report is for the previous 1 year. So I thought it's okay to have it there. Then Dasi, Shalini went all the way to Pune, and now she knows how to do the Dasi properly. And we have a robust milk bank that is running. Point of care testing is available. You can see Sakshi there looking at CSF probably, and for diagnosing meningitis, because by the time it goes to the lab, you don't know whether they slept over it the whole night and then they are reporting 0 cells or whatever. So then whole body cooling, bedside ultrasound and echo, EEGs that are done in the department, and also amplitude integrated EEGs that are done in the NICU. And OPD, we have specialty clinics running in the OPD. So there is a pulmonology clinic, TB and pulmonology, endocrinology, Tuesdays we have neonatology, under supervision of Dr. S.N. Singh. Then Wednesdays again we have a neonatology clinic and a nephrology and thalassemia clinic which happens in the ward. Then on Thursdays we have neurology and oncology clinic and also cardiology which Neeraj looks after. Then hemato-oncology and gastroenterology on Friday, and Saturday nephrology and neurology. And Thursdays are really busy days where Chandrakanta keeps grappling with her neurology patients till 4 or 5 p.m. She and her team. So those are the specialty clinics that we are running. Then in the IPD we have more than 4,500 admissions every year. And I mean this year we had PICU mein around more than 600, neonatal unit around 2,000, oncology they had, this is incorrect, 20 new cases. No, 209 new cases, and thalassemia, but 39 new cases of thalassemia were registered. And in the OPD, the count is almost 65,000 that we saw up till now. That is October 24. So a word about faculty recognitions and responsibilities. So I'm currently the president of the UP National Neonatology Forum, and I'm happy that we could develop a CPAP training module and a bridge course for medical officers working in the PHMS who will be empowered into newborn and pediatric care. Then I'm a member of the Committee of Task Force for Reducing Neonatal Mortality in UP and a member of the Ethics Committee of SGPGI and a Technical Working Group for Revising Operational IYCF Guidelines, part of the member of the Apex Advisory Committee of KGMU, and also the Vice Chairperson for the Task Force for Safety of Women in KGMU. Really has been a big thrust of the Vice Chancellor, Honorable Vice Chancellor, ever since whatever happened in Calcutta. Nodal Officer for State Newborn Resource Center and the Comprehensive Lactation Management Center. Dr. Professor S.N. Singh is a member of the Accreditation Group for Neonatal Care by the NNF. He's a master trainer for many neonatal and child health related training programs, and he's a nodal officer for Faculty Awas in KGMU and a provost of the old CD hospital. And this is a picture of Dr. S.N. Singh in the annual presenting in the annual scientific meeting of Respire 2 project in Sri Lanka in August 2024. Chandrakanta, who's pursuing advanced course in medical education, and she's a member of the curriculum committee of KGMU, has 3 publications in the last year, has 1 research project running, and she has participated as faculty in the National Pediatric Stroke Conclave in Bangalore and in the UP Pedicon in Lucknow. And she's presented a poster in Colombo this year in June also. Those are pictures. She's very reluctant to share any pictures, and this is the last time, at the last moment that these pictures were squeezed out of her. Literally, Chandrakanta, modest about. Nishant, he's another one. His pictures came in late. Hey, madam, no picture hi nahi hai. So he's a member of the INPHOG and has 7 multicentric projects to his credit, and he's delivered several invited lectures. A list of those, and those are some pictures of him. Then Shalini, who's a subject expert of research proposals, and she's a member of the DCGI, and she's certified to do DASI, and she's a member of the TEG, the technical expert group for the development of that CPAP module that we were talking about. And those are beautiful pictures. She is one person who takes a lot of pictures, posts them on FB, keeps them with her, and gives them very quickly. And we all learn from her कि भाई photo खींच लो जरूर. Yeah, it helps so much. Then here we have Sarika. She is another one who's very fond of taking pictures, and look at the list of things that and sharing. And she was awarded the FRCPCH this year. And she is an expert in drug-resistant tuberculosis, a nodal officer for the Center of Excellence of Pediatric TB, and she's a trainer at the national level for respiratory module under the IAP. And she's also the deputy medical superintendent of the trauma center here, provost of the VL Hall, and a co-convener of the grand rounds that we have every Saturday, and a divisional coordinator also she was for the IIP UG quiz. And those are beautiful pictures, always well dressed and always looking so pretty. So then we have Arpita, who's another one, and she has been going to all sorts of schools. She still likes to go to schools. So you see in the first picture at the 23rd International Society for Pediatric and Adolescent Diabetes, ISPAD, Pennsylvania, USA. This was a science school. Then the next one was at 10th European Society for Pediatric Endocrinology, which was a dorm school. I forgot to ask her what is a dorm school. And then we have the 37th European Society for Pediatric Endocrinology, which was a summer school. So she has really been going to a lot of schools. And now she's full of knowledge, and now she'll teach us all endocrinology. Then we have Arisha, who got a certificate for eminence in research, and who also was part of the workshop on Cochrane protocol development. She is fond of research, and she also does neurology. Neeraj Anand, who used to be the baby of the department till the 4 new faculty came in, has now grown up. And here he is seen in the IMNCI regional training of trainers as a trainer. And he is the one who helped us with the advanced pediatric life support workshop that we had. And he's also finished doing his new focus. So that is Neeraj, a lot of potential in him, and he's really moving forward well. Then the residents are not very far behind. So we have some pictures of the residents, and here you can see all of them so enthusiastically presenting posters and winning prizes, and sometimes not winning prizes, but always being there, representing all of us. Ranvijay, Twinkle, Deepti, Sujata, so all of them can be seen here. Then you have Simran, who got the gold medal for the award paper recently, Dr. Tapan, who presented a poster, Himanshu, who in the Respicon presented a poster and got an A plus grade for that. Sakshi, who presented a poster in Portugal, and Twinkle, who presented an E poster in RCPCH. And this is another one in Paediatrics in 2023, end of 2023. Then we are also active on the e-platforms. With COVID came the e-platforms, and in a way that was good because we could interact with so many people at the same time. So the IAP, they set up this academics with institutions, and every time this thing was given to one of the prominent institutions of the country, where we had to tell everybody about our institution. So we got a chance to participate in that. Then the UPNNF also a case was presented, and by one of our residents under Shalini. Then we participate in IAP and NNF quizzes, and we got pictures. Sometimes we win, sometimes we don't win, but the pleasure is in participating and getting together. Then workshops and conferences that were organized. So there's a whole lot of workshops, and many of them doing with neonatology, as you can see, training of trainers or CPAP training, training of trainers for bridge course. Then endocrine course was held in this year with the help of Arpita, and PALS training and NBSU training and all that goes on round the year. Then these are pictures of the practical pediatric endocrinology course, which Arpita arranged so fabulously. Then there was this workshop on research methodology in UP Pedicon, October 2024. Then NeoShine. So NeoShine was organized by our president, the president of NNF, Dr. Sushma Nandya. And when she told us about it, we were really wondering how we'll be able to do it. But she did it, and we did it with her. And here's the picture of us participating in that NeoShine program for PGs. I think the PGs also ultimately enjoyed the program only and learned something from it. Yeah? Okay. So interdepartmental activities. Dr. J.D. Rawat is here with us, and we like to coordinate with them. We like to coordinate with OBS and Gynae in a big way. So a few lectures were organized. And here Dr. Shweta Pandey from neurology came and told us about the nerve conduction velocity. Then Dr. J.D. Rawat spoke to us about the pediatric abdomen, and he's with us today also. He's the head of pediatric surgery. Then Vishal went to pediatric surgery and talked about IV fluids, and Neeraj talked about ventilation along with Dr. S.N. Singh. Then we also tried to interact with other people, so we had invited guest lectures. So Dr. Roli Srivastava, who is an MD from our own student, is now a pediatric cardiologist in Medanta. She came to us one day and we enjoyed being with her. Rahul Bharat, who came, he's a pediatric neurologist from UK, and Dr. Bharat Dubey from the Apollo Medics Hospital, who is a CVTS surgeon, and Dr. Shubha Fatke, who is the head of genetics. These were some invited guest lectures in the year. Then, no department can flourish without the nurses. So, here I'm going to talk about them briefly. So, beautiful sisters in charge and handsome brother. If I call him beautiful, you'll be angry with me. And they are overseeing a squad of 245 nurses. And I'm grateful to our VC who gave us a squad of 78 new nursing officers this year. I think we should give her a big round of applause for that. Then we try to organize training sessions for nurses, as you can see here, NICU, PICU primarily. And people from the nursing faculty also come to us to train our nurses. Then we do some outreach activities, television shows, radio goonj, school camps, and so those are there. Pictures of everybody, Smriti, here Sarika, myself, Shalini, and those are our residents in a school camp. We'll not be able to function as well as we do if we did not have support from NGOs. The university and the government, they support us in a big way. But there are certain small things for which we have to run from pillar to post. But because of the Varsha Foundation and the Hari Om Seva, especially, we get a lot of support. See what they did for us. The residence room. One of our endeavor is that the working atmosphere should be congenial. Nobody likes to work from a dirty office, from a dirty room. So here we have the newly refurbished residence room. This was courtesy Varsha Foundation, and the residents look happy there. It's neat and clean. And we always remember Dr. Rashmi Kumar, who as the head of the department used to go to the residence room and clear up the place. Putting the case sheets away, putting this away, things used to be shoved under the bed. हाँ देखिए अब बता भी रही है तो वो सब निकलवाती थी, सब करती थी. So now, ma'am, the thing looks like this, the residence room. You will be happy to see. And this is the nursing, the room where the nurses sit. So this is also refurbished by the Varsha Foundation. We are really grateful. Mr. Harsh Khanna is with us today. So thank you for this. Then that doesn't end there. Here is the HDU. So our very sick patients used to run 103, 104 temperature, and we didn't know what to do, where to keep them, because most of the rooms are not air conditioned. So with his help, we could put in an air conditioner there, and now we have 7 beds, which are the HDU beds. So the very seriously sick children can be placed here after they are in the emergency for the first 24 hours. This is a patient who has been helped with medication, courtesy the Varsha Foundation. Thank you very much. They help us arranging blood, they help us arranging albumin, I don't know with what all they help. Sometimes they even help us to send dead children home. So thank you very much for that. We are grateful. Then we have a few success stories. This is a child who had Madhya, who was with us for 7 months. She had GB syndrome. And I think all the residents must have taken care of her because their postings keep changing every month. So she was on the ventilator, off the ventilator, VAP, this, that, everything. And ultimately she went home. And after 7 months of being with us, she came to the OPD recently and she's very much better than before. And this is another baby. Shalini went shopping to the mall and there was this lady who recognized her suddenly. So my baby was 800 grams and look at the baby, it's here. She got a little discount also on that day shopping. So those are us. It really makes you so happy. That 50 rupees discount is not the thing that is important. But the thought, that chalo maine iska picture click kiya, so she's happy. Now, some people retired. Sister Rekha Sahai, who was sister in charge, children upstairs, Shri R.P. Avasthi, who Dr. Archana Kumar and Rashmi ma'am, they know him well. Usha, who was a sick attendant, they retired this year. And there are some people who left us. There was Ajay Nishad, who was a sick attendant. He committed suicide. Pinky, who was a Safai Karamchari, and Chandra Bhushan, who was not very well. They left us this year. Then celebrations. So how can there be a department, a children's department, doesn't feel happy about things, doesn't celebrate things? So here we have World KMC Day, the Newborn Week, the ORS Day, Milk Bank celebrated its 5th anniversary with the cake and all. Then Asthma Awareness Program, World Pneumonia. So if there is an occasion, we like to celebrate. And we like to take pictures because we need those for the NMC accreditation. And many a time they are geotagged. So here we have the Anemia Day celebration, the HLA camp, the World Prematurity Day, Retinoblastoma Awareness Day, One Mahotsav, and Childhood Cancer Awareness Activity. बहुत सारी होती हैं. I've just picked up a few of the pictures. Then this is what the Dream for Summer Camp for Type 1 Diabetes organized by Arpita. Then we have the World Diabetes Day celebration, the Nutrition Week celebration. Name it and it's there. Independence Day, 26th January, Teachers Day celebration, and Diwali celebration. So we can't burst crackers in the department. So we had a little Rangoli program for nurses, and prizes were given for the best too. And then we celebrated Holi. This is in the seminar hall. So we try to keep it dry, but yes, we do it. Then birthday celebrations. So many of them, balloons and things all over the place. The residents do this for the faculty. So just 4 of the birthday pictures are here because putting too many would be difficult. New Year celebration. So whenever there is an opportunity, we celebrate. Now a little analysis. Our strengths. I think our biggest strength is young and dedicated faculty. Most of our people, 11 out of 14, are less than 45 years old. That's a big thing. And immense support from the university, government, and the NGOs. I think that is our strength. We just have to make a request, and if feasible, that request is taken care of. Thank you, ma'am, for that. Then we have a few limitations. So we are short of faculty. 19 sanctioned posts we have, but we have only 14 people in place. And that really becomes difficult. Sometimes we have 3, 4 candidates doing their thesis under one professor. Then the building is old. Off and on, sisters come running, ki madam, wo chhat gir gayi. The false ceiling has fallen, this has happened, that has happened, so that's scary. So we can do something about that. And there is a lack of space in the ICUs. The beds have increased, but the space is the same. So those are our limitations. Then we have future plans. The first one on our list is capacity building of our ICU nurses. Now that we have 78 new nurses, we better take some care in training them. Networking through telemedicine with other institutions, with other smaller hospitals. Then we want to help the government build a robust referral system. It's a big pain. There is no referral system. Newborn and other patients, sick patients, they just keep dashing between institutions. Then we want to start DM programs in pediatric subspecialties and ultimately develop an Apex Pediatric Center, for which our Honorable Vice Chancellor is also trying very hard. Thank you very much for having a glimpse of our activities of the previous year. As I said before, this is a trailer. The movie is a 2-hour movie, so we're not going to do that. Thank you very much.
Thank you, ma'am. Now I'll request all the dignitaries to come forward to honor our esteemed orators and speakers for today by presenting mementos to them, a token of gratitude and appreciation for their contributions. First, I would like to invite Professor Swarup Datta, sir. late Professor P.K. Mishra Oration is being conferred to Professor Saurabh Datta. I would request Professor Rashmi Kumar ma'am and Rashmi Kumar ma'am to please join me. Thank you, sir. So late Dr. N.L. Sharma Oration is being conferred to Professor Monica Juneja, but sadly ma'am could not come in person. We will send her oration to her. Appreciation certificate for Professor Rashmi Ranjan Das, who has come all the way from AIIMS Bhubaneswar to deliver this talk. An appreciation certificate for Professor Nirmalya Roy Maulik, who has come from GMH Mumbai to deliver the talk. Now we have awards for our staff. We would like to appreciate the contributions made by our staff, so we will be honoring them. So among the staff nurse category, I would like to invite Mrs. Malti. Mrs. Malti. She's always follows orders with a smile, Mrs. Malti. Best Sister Award, Best Staff Nurse. Mr. Basant Pandey for the Best Office Staff, Mr. Basant Pandey. Mr. Anil Kumar Singh, the Best Sick Attendant, a quite respectful Mr. Know All, Mr. Anil Kumar Singh. Mr. Jagdish, the best peon. He is the gate pass to the HOD room. Miss Priyanka, the best support staff. She's an honest, hard worker, intelligent, works beyond her boundaries. Miss Priyanka. Mr. Sujat, he's an accountant in the BPL section. Mr. Sujat, he has been a helping hand who has been helping with Vipanna process very quickly. Mr. Ram Prakash, the best Safai Karmchari. He's a silent, conscientious worker, Mr. Ram Prakash. Mr. Syed Alam Khan, the best security guard, a punctual, diligent and well-mannered. Mr. Basant Pandey is here. He's the best office staff, very efficient in writing letters and finding solutions. Thank you, everyone. Now I would request the Honorable Vice Chancellor to bless us with her kind words.
Thank you, Dr. Nishan. So, Dr. Archana Kumar, Dr. Rashmi Kumar, who have also been my teachers. And of course, the orator for today, Dr. Saurabh Datta, who's come all the way from PGI Chandigarh. Dr. Monica, even if she's not there, but I would like to acknowledge her. Professor Rashmi Ranjan and Professor Nirmalaya. All the other esteemed faculty members, Dr. Oja, the CMS, all the other esteemed faculty members of the Department of Pediatrics and from KGMU, and all the staff, most important, the students, the residents, the staff of the Department of Pediatrics. First of all, I would like to congratulate each and every person in the department for this wonderful journey and to bring the department to this height, which was so evident from the report which Dr. Mala Kumar presented. हर जने का इसमें contribution है, हर जने का. And Dr. Mala Kumar, your leadership is awesome. You presented such a wonderful, great report that I really don't have anything much to add. It was a very comprehensive, detailed, and very well presented report. I just would like to, I've been a hands-on witness to the CPAP training that this department is conducting along with the UP government and the UP Technical Support Unit for the different neonatal care units, small baby neonatal care, the SNCUs from all over the state and trying to cover the different districts. And I know how much of effort and how much of detailing has been put in to make the training modules, especially by Dr. Mala Kumar and the rest of the team. So I know it's a department which is very, very productive and has a lot of flagship programs which are running in it. I just want to add on that we will support you from the side of the administration to start your different super specialization courses. You're actually ready for it. Almost every faculty has developed, it was very evident from your presentation, a niche area of specialization. You just need to start putting in units of 3 faculty with a non-overlap with the faculty who will be counted towards the MD course. So it would be nice now if KGMU takes a lead role and the Department of Pediatrics in starting these DM courses. At least I feel you should start with one or two DM courses this year. You're really ready for it, you know. We are trying at least one part of the the burning need of the department of having an expansion of the neonatal ICU. We are trying to fulfill in the land which is available behind the Queen Mary's Hospital by trying to give you some more beds for the neonatal ICUs in that area, and I think it will come up very soon because the whole proposal has already gone to the UP government, and also there will be a pediatric critical care medicine. So at least that part can be taken care of. And as far as the Apex Pediatric Center goes, it's a little difficult because you know that in the recent past, the Sanjay Gandhi PGI has been given an advanced pediatric center. Though the university here has a big basic department of pediatrics, and it would have been good to develop an advanced center around that basic department. But yet we will work towards it. And it was very pleasing to hear about the evening teachings, because I strongly feel for the evening teachings. From the day I stepped into the university, I've been echoing about evening teachings, because in my undergraduation and post-graduation, I found the evening teachings to be actually of use in my clinical training. So I'm so happy that you maintained the tradition of evening teachings, at least in the Department of Pediatrics, because to me it seems that it has died down in many other departments. And your research footprints was very impressive. I think with 54 papers or 52 papers, it was very impressive. And it's good to see that besides service, the department is also engaged in academic and research pursuits. And I again would like to support that. Good research projects which are running in the department and which are not just funded by pharmaceutical industries, but I saw there were a lot of ICMR projects also. So it would be nice that that tradition is kept on and more projects are developed by the faculty. And the 4 new faculty who have joined, a very warm welcome to all of you. And I must say that they've all been selected on they've been very meritorious faculty. And no doubt you have a loss of one person who was a nephrologist, pediatric nephrologist. But when one door shuts, there's always a door which opens, and you've got 4 new faculty who are very, very good. So my good wishes for the department. I have really nothing more to add after such a comprehensive and coherent departmental report, except that I would just want to assure you that we are all there. The institute administration is there to support the department in its growth and development. And my good wishes that under your leadership, the department is progressing so well. And I'm sure Dr. Rashmi and Dr. Archana must be very happy to see that the seeds that have been laid by the previous head of the departments, that plant is growing and growing and growing. Thank you very much for inviting me today. And जितने भी यहाँ कर्मचारी आप लोग सबको हमारी बहुत शुभकामनाएं. ये दिन आज आप लोग का है. आप लोग इस डिपार्टमेंट को इस स्थिति पे लाए हैं. So आप लोग को बहुत बहुत शुभकामनाएं जितने भी कर्मचारी हैं. धन्यवाद.
Thank you, ma'am, for those kind words. With this, we come to an end of the inaugural function. I would like to invite Professor Chandrakanta, ma'am, to propose the vote of thanks.
Thank you, ma'am and Nishan, for giving this present duty to me to propose a vote of thanks. So first of all, I wish to extend my sincere gratitude to our own Vice Chancellor, ma'am. And ma'am had given constant guidance and support to us every time we were we requested her. And thank you, ma'am, for blessing us today with your gracious presence. I thank our guest of honor today, Professor Monica Juneja. Unfortunately, she couldn't join. She will be joining online. And Professor Saurabh Datta, sir, from PGI Chandigarh, for accepting our invitation to deliver the oration and attending this function. Thank you, sir. I thank Professor B.K. Ojha, sir, CMS KGMU Lucknow. And sir is very busy, always with the hospital work. But despite that, he visited us and find time for us today. Thank you, sir. And I thank our own Rashmi madam and Ashna ma'am for being us with today. So Rashmi ma'am, actually, she taught me ABCD of neurology and ABCD of EEG. So I always I have a gratitude to her. And Dr. Ashna Kumar ma'am, thank you ma'am for coming here. She was my thesis guide and she taught a lot of things, not only about the pediatrics, but also about the life and the moral duties. And I thank the other faculty members from other departments, respected HODs and other faculty members, Professor Puril sir, Professor Sunil sir, Pradeep Tandon sir, and Madam for coming here and you spent time with us. Thank you. Thank all the media person, IT side, KGMU Gunj for a nice coverage and giving technical support during this celebration. And I also want to thank all pharma companies who have generously supported this function, East India Life Cell and the other companies. And in the last, I thank all the faculty members of Department of Pediatrics, residents, nurses, office staff, class 3 and class 4 employees for making this event successful. So thank you all.
Very good morning.
She has to make a unit, but
unit बना लीजिए.
So I would request all of you to take your seats. So now is the time for academics. We have some beautiful talks lined up for today's orations. I would like to first call upon Dr. Shalini to introduce our first orator for today.
Thank you very much, Dr. Nishan. So now we are moving to the academic sessions. It is my proud privilege to introduce Professor Saurabh Datta sir. And Dr. Saurabh Datta is a professor in Neonatology Division of Department of Paediatrics at PGIMER, Chandigarh. He did his MBBS and MD from the All India Institute of Medical Sciences, New Delhi, and was awarded a PhD in Neonatology from PGI Chandigarh. He was awarded FRCPC in Pediatrics and FRCPC in Neonatal Perinatal Medicine from the Royal College, Canada. He was earlier a full-time faculty member in neonatology in the McMaster's University Children's Hospital, Ontario, Canada. He continues to serve as an adjunct professor in the McMaster's University Children's Hospital till date. He has been elected Fellow of National Academy of Sciences of India, NASI, a Fellow of National Academy of Medical Sciences, NAMS, and a Fellow of National Neonatology Forum. Sir has over 200 publications, 37 chapters in books, and currently has over rupees 16 crores as research grant for ongoing projects. He holds a patent for novel devices. His area of interest are neonatal sepsis and breast milk microbiota. He is a passionate about teaching and research methodology and has conducted numerous workshops in this field in India and overseas on research methodology. So now I would request Professor Saurabh Datta sir to deliver the first oration. Sir, please.
Yes, pointer. Professor Rashmi Kumar, Professor Archana, all the dignitaries, faculty members in pediatrics, my seniors, residents, other members of the staff. It is indeed a great honor and privilege to have been asked to deliver the Professor P.K. Mishra oration on the occasion of the 71st Foundation Day. Although it's the 71st Foundation Day, but I believe in its previous avatars, this institution is more than a century old. And whenever one comes to KGMU, one is always overawed by the sheer history of the place, KGMU. I'm particularly thankful to Professor Mala Kumar, although she's several years my senior, but her affable and informal demeanor, her lightheartedness, sense of humor always makes her more of a friend than a senior. Thank you, Professor Mala, for this invitation. Now, we have all gathered here to pay tribute to the late Professor P.K. Mishra. I don't need to inform this audience, you're familiar with her. She was former principal, dean of the Faculty of Medicine and head of the Department of Paediatrics at KGMU. She is a Dr. B.C. Roy awardee, a Vigyan Ratna awardee, amongst many, many other awards that she received. She was a fellow of several national bodies and of the International College of Pediatrics, USA. And when I was unlucky that I never got to actually work with her in person, but I've heard so much about her that I'm really privileged that I've been asked to deliver an oration in her honor. I was going through the internet and I could still see the wonderful obituaries that had been written in various newspapers published from Lucknow when she unfortunately passed away after a respiratory illness. So why am I talking about neonatal meningitis? The prevalence of neonatal meningitis is higher among neonates than any other age group. So if anyone should be talking about meningitis, it is people who deal with neonates. Secondly, the long-term consequences of meningitis are far more sinister than just sepsis without meningitis. And these consequences last a lifetime. Lumbar puncture, being an invasive procedure on a highly vulnerable organ, the central nervous system, is because of that, it is much more difficult to investigate meningitis compared to sepsis. It's very easy to take a blood sample, but it's much more difficult to take, say, a ventricular fluid or a cerebrospinal fluid sample. And the trouble is that ethics committees are very reluctant to permit repeated lumbar punctures being performed, making research into this area very difficult. So if you want to see how meningitis is progressing or not progressing, it's almost impossible because you cannot do repeated lumbar punctures. No ethics committee would allow it. So therefore, our collective ignorance about neonatal meningitis, in contrast to sepsis, is actually appalling. There's very little that we really understand about neonatal meningitis. And I am going to try in the next half an hour or 45 minutes to try and at least remove some of the cobwebs around this whole issue of neonatal meningitis. So the overview of my talk is going to be as follows. We all know that patients who are symptomatic of sepsis, whether it's early or late onset sepsis, should undergo a lumbar puncture. But quite often we ask ourselves this question on the rounds: are there any neonates who are at such low risk of meningitis that we can actually identify them and avoid doing an LP? Why make every neonate undergo an LP? The second is, how do we interpret the CSF findings, cell count, glucose and protein? Does the delay in analysis of the CSF alter the CSF findings so that your diagnosis itself changes? Because we are relying so much on these three parameters. Are there any point of care tests available for CSF glucose and CSF cells so that we can quickly get a diagnosis? How do we interpret traumatic taps? Traumatic taps are far more common in the neonatal period compared to any other age group. Is there any role for other inflammatory markers, say CSF procalcitonin, for instance? Is there any role for molecular testing, PCR and DNA sequencing, for establishing the diagnosis of meningitis? How long does it take for abnormal CSF findings to normalize after you have started antibiotics? Which is a very crucial clinical question. And how long finally should one treat with antibiotics? So I'm going to try and cover all of this. I've chosen some things because I have personally done research in these areas, so I wanted to bring it in front of you. So the first question: are there some neonates at such low risk of meningitis that LP can be safely avoided? So let me first start with late onset sepsis. So this is data from several well-designed, prospective, non-case controlled design studies, just looking at the sheer prevalence of meningitis in suspected late onset sepsis. So here are various studies. The years are given. None of them are too old. They're fairly recent data and reasonable sample sizes. Our own study figures here at the bottom. And if you just eyeball these numbers of prevalence, you'll realize that the ballpark figure, I'm sorry, part of it has gone outside the screen. The ballpark figure is, amongst anyone in whom you're suspecting sepsis, about 5 to 10%, sometimes it goes up to 15%, will have meningitis. And that's a big figure, because you're suspecting sepsis in so many neonates. So if the ballpark figure is 5 to 10%, you're dealing with a fairly big burden. So therefore, a lumbar puncture must be performed, and that's been the dictum so far, in all cases of suspected late onset sepsis and symptomatic early onset sepsis, because in the beginning, it is not possible to predict in advance who will turn out to be blood culture positive, who will turn out to be proven sepsis and so on. So you are left with no other option but to do a lumbar puncture. And there is a high incidence of meningitis even in those with negative blood cultures. So you cannot even say that, okay, I'll wait till the blood culture report comes, then I'll do a CSF, because you never know. It may still be meningitis. Okay. So this was the question. Is there any low-risk subgroup in which I can safely avoid doing a lumbar puncture? So to answer this question, we did a study which was published in 2020 in the American Journal of Perinatology. So we took 300 lumbar punctures for suspected late onset sepsis or symptomatic early onset sepsis. And in all of them, we recorded a lot of information prospectively. The information was details of demographics, 17 clinical signs of various kinds of sepsis, all kinds of laboratory tests, sickness severity scores, organ dysfunction scores, whether the symptoms are localized to a single organ or not. What we were trying to do is look at patients who are finally diagnosed to have definite or probable meningitis and associate them with all this data that we had collected in a univariable analysis. What we found that there were 13 variables which are all listed here. You can just look through them, which were associated with definite or probable meningitis. So now we said, okay, what about those who don't have even one of these 13 parameters? That would identify a very low risk subgroup not associated with meningitis. So we had 58 subjects who did not have a single of the above variables. That means a very low risk subgroup. And we also tried all other kinds of permutations and combinations to try and get as low a low risk subgroup. And to our shock and surprise, we found that even among them, 29% had possible meningitis. That means they had cell counts, protein and glucose, which were too close to the cutoff for meningitis to be comfortable that you could say, okay, we don't need to do an LP. So our conclusion from this study was that there is actually, at the present day, with the present state of knowledge, there is no subgroup in which you can say a lumbar puncture can be safely avoided. That the baby looks okay, not that sick, so let's not do it. You have to do it in everybody. So that's the message from this study. Second important thing is, how do we interpret CSF findings? There are cutoff values of CSF, WBC, glucose and protein reported in literature. There is a wide range of values, but in a scoping review, we found that the most, within quotes, popular and accepted cutoffs range what I have shown on this slide. That for WBC, in term neonates, most authors agree that it's positive if it's more than about 20 to 25 cells, mostly polymorphs. In preterms, if it's more than 25 to 30. Glucose is positive if it's less than about 33 to 40 in term and less than 23 to 24 in preterm. And protein in terms, anything more than 120 to 170, that's where the ranges usually lie. Preterms 150 to 170. So what we did was, and this was published just last year, we for the first time did a diagnostic test meta-analysis, a systematic review of all studies that had been published on these parameters. So for the diagnosis of CSF, WBC count, glucose and protein for the diagnosis of bacterial meningitis in young infants, our reference standard was either CSF culture positive or gram stain positive or PCR positive. So we identified a huge number of records, extracted the full texts from 1,313 records, which we all had to sit and read all of those full texts. Finally, we included 16 articles for the quantitative meta-analysis. And this is the standard risk of bias table, which has a reasonable number of green circles and a smattering of red circles, which means some of them had high risk of bias, but overall acceptable. So this was the result of the meta-analysis. So this is for WBC, protein and glucose. Here are the number of studies of each of these and the number of participants. You can see a fairly large number of participants, more than 30,000. Now what I want you to focus your attention on is on the pooled sensitivity and the median specificity. So these are the median specificities of these. And you can see that the sensitivity of WBC and protein is much higher than glucose. That's number one. So from that, you get, from sensitivity and specificity, you get something called the likelihood ratio of a positive test and the likelihood ratio of a negative test. I'm not going to go into the statistics of it. But at the end of the day, we calculated what is known as an area under the ROC curve, which in one figure gives you how is the overall test performance, how is the trade-off between sensitivity and specificity of these tests. And here again, you can see I've highlighted it. WBC and protein performed better than CSF glucose. So if you have to choose between these three, CSF, WBC and protein is better than CSF glucose for diagnosing neonatal meningitis. We went a step further, and this is a very, very important slide. So I want everybody's attention on this. We calculated the post-test probability of meningitis. That means you've done your CSF, you've got the report. Now, if the test is normal, what is the probability of meningitis? If the test is abnormal, what is the probability of meningitis? This is what a clinician wants to know. So, and there could be various scenarios depending on how sick the baby was at the time when you did the LP. So that is called the pre-test probability. So there are three scenarios. Say a 2%, roughly a 2% risk of meningitis, the kind of baby who's not sick, LP is just being done to rule out sepsis, a few minor signs of sepsis. A 5% probability, that's the kind of a run-of-the-mill sepsis patient. 10% probability of meningitis, child quite sick, maybe some neurological signs as well. So here, all the orange horizontal lines are where the CSF result was abnormal. The green lines are where the CSF result was normal. Now let's first look at all the green horizontal lines. So it tells us a very interesting story that WBC, protein, glucose, irrespective of how sick the baby is to begin with, if you get a normal CSF protein and glucose, you have virtually no chance of it being meningitis. See out here, 0, 0, 0, 1%, here there's 1 and 0%, here there's a 1. With glucose being a relatively inferior test, there's still a 3% probability. But more or less the headline from this slide is, if your CSF protein, glucose and this are all normal, there's virtually no chance of, or very, very little chance of it being meningitis. But what if it is positive? If WBC protein or glucose is positive, it's not a sick-looking baby to begin with, you're somewhere around, there's a 15 to 16% chance of it being meningitis. If it's a little sicker baby, there's about a 25 to 30% chance of it being meningitis, this row. And very sick baby, even with neurological features and so on, at best, it's about a 45 to 50% chance of it being meningitis when these tests are positive. Now that is scary because, okay, normal parameters are good for excluding meningitis, but an abnormal parameter, even in a sick neonate, you will still be over-treating more than 50% patients as meningitis because the probability is hardly about 48% at worst. So 52% of our patients are all being over-treated for meningitis based on CSF, WBC, glucose and protein. And that was a very important lesson that we got from this systematic review and meta-analysis. That means these are not great tests for proving the diagnosis of meningitis. They're only good for excluding if they are normal. Now, does a delay in the analysis of CSF samples affect WBC and glucose? So we did the study which we had published way back in the Archives of Disease in Childhood in 2009. So what we did was, we took the CSF samples within half an hour, by the clock, we measured the cell count, glucose and protein, and then from that same sample, which allowed it to stand for 2 hours, 4 hours, we again pipeted out sample and did the cell count and glucose and protein at 2 hours and 4 hours. And this is what we found. So the blue line is CSF glucose, the red line is a CSF WBC count, the green line is the neutrophil count. And you can see that glucose, WBC and neutrophils all declined. In fact, this decline in WBC count was quite shocking by 2 hours and 4 hours. And a 2 hour delay in CSF is no big deal. It happens in all public sector hospitals. So in fact, we found that the changes are so much that your entire diagnosis changes. So if you're sitting at a WBC count of say 40, it is enough to change your diagnosis because it is now dropped to less than 25 cells, and vice versa for glucose, because hypoglycemia proves this meningitis. So this is a serious problem. Fortunately, there is a way of back calculating what the true value would have been by these linear regression equations. So we found that there is a very linear relationship between the true WBC count and the 2 hour WBC count, as long as you know that 2 hours have elapsed. Means the lab has to tell you when they actually did the test. So you can actually back calculate. So from the 4 hour and the 2 hour counts, you can find out what was the actual count. Okay. So now if there is this decline happening, a spurious decline, is it possible, we ask this question to ourselves, that we do a point of care test for the CSF glucose to avoid this spurious decline with time? So what we did was, we said, okay, is it possible to measure the CSF glucose using a blood gas analyzer? So most ABG machines these days have a glucose, or blood glucose being reported. So can we use that for CSF or a glucometer? So this is what we found. So these are scatter plots of 97 neonates with suspected sepsis undergoing lumbar puncture. This was published just, I think, 2 months ago in the Journal of Perinatology. So what the left graph shows is that this is the gold standard, the lab CSF glucose on the x-axis, and this is the arterial blood gas machine CSF glucose on the vertical axis. This line is the 45 degrees line. So points on this line mean that there is complete agreement between the lab glucose and the arterial blood gas glucose. If it is deviating from the line, it means the results are not agreeing. So this is for the ABG, and on the right side is for the glucometer CSF glucose. And as you can see, that for the ABG machine, it's performing pretty well because most of the dots are actually on this line. But you can't say the same for the glucometer glucose. It's deviating from this dotted line, which is the 45 degrees line. So we did what is known as a bland Altman plot without going into the statistics of it. This is a way of seeing whether two continuous variables agree on their measurements. So what is done in this is that on the horizontal axis, you take the average of the two measurements, the CSF lab and the ABG glucose. And on the vertical, you take the difference, the arithmetic difference between the two. So this is done for the left graph is for ABG, right graph is for glucometer. What we found was that on an average, the difference between the lab glucose and the ABG glucose was 2.47 milligrams per deciliter. The ABG glucose was over-reading the CSF glucose by 2.45 grams, which is not a big number. But for the glucometer, I'm sorry, it's gone out of the screen, it was 15.5 milligrams per deciliter, enough to swing the diagnosis one way or the other. And we also found that the dispersion of values, the difference between the two was more when the CSF glucose was above 75 milligrams per deciliter, which is good news because as neonatologists, we are dealing with low glucoses. It's at the range of about 20 to 40 where you want to have maximum agreement in the glucose. So who cares, if it's above 75, it's not agreeing. So what we concluded from this was that we can use CSF arterial blood gas machines for measuring glucose, but we cannot use glucometer for measuring glucose as a substitute for lab glucose and for getting an immediate result at the bedside and avoiding this spurious decline of glucose values. The next question was, can we do a point of care test for CSF WBC? And we said, why not use leukocyte esterase dipsticks, the kind that you use for urine, and use the same thing for CSF WBC. So we took 344 neonates with suspected sepsis based on NeoKISS criteria who are undergoing LP, and this study is currently under publication. So what we did was, from our past experience, we knew that we had to measure the reference standard within half an hour, otherwise the WBC count would decline. So in all of them, CSF leukocyte neutrophil was performed within 30 minutes of performing the lumbar puncture in a side lab. The CSF leukocytosis was defined a priori as more than 25 cells per microliter, neutrophilia as more than 15 neutrophils per microliter. And apart from the routine CSF tests, we also kept some extra CSF samples. So 10 microliters of CSF was pipetted onto the multi-sticks, which had leukocyte esterase and read as nil, trace, small, moderate, or large. And a priori, we had said that a positive leukocyte esterase would be defined as moderate or large on that multi-sticks. And this is what we found. We found that if you looked at a correlation between CSF leukocyte esterase values versus the lab values, the gold standard, we calculated a coefficient of correlation. For leukocyte count, it was 0.49. For neutrophil count, it was 0.44. And although these p-values are significant, this strength of correlation actually is not great. It's less than 0.5. You're looking for something which is at least 0.7, 0.75, 0.8 strength of correlation. So correlation is not that brilliant, although it's statistically significant. For protein and glucose, of course, it's very low. And the accuracy to predict leukocytosis as defined as more than 25 cells was actually quite bad. The sensitivity was only 63%, which means that of all those who really had leukocytosis, only 63% was being picked up by leukocyte esterase. Specificity was acceptable, but then for a disease like meningitis, you want high sensitivity. You don't want to miss someone who has meningitis. So our conclusion from this that leukocyte esterase really cannot be used routinely. It has a poor sensitivity and only a modest correlation with WBC. Now, traumatic LPs are a big problem. So what do we do with traumatic LPs? We have always been taught in textbooks that you should apply various correction factors, a ratio of RBC count to WBC count and so on. So in 2008, Greenberg et al. Published this landmark study. So they took traumatic lumbar punctures defined as more than 500 RBCs. There were more than 6,000 LPs, of which 40% were traumatic. Amongst these traumatic LPs, the median RBC count was as high as more than 4,500 red blood cells. So they had uncorrected WBC of controls which are non-traumatic. they had WBC corrected, all these are traumatic, corrected by using, uncorrected and corrected using various formulas, 500:1, 1000:1, and so on and so forth. Now, the important thing is they calculated the sensitivity, they calculated the specificity of these various ways of correction versus not correcting at all. And they found to their surprise that when they calculated the area under the curve, ROC curve, which gives an overall estimate of the test and which is a good trade-off between sensitivity and specificity, the area under the ROC curve was actually almost the same, identical, irrespective of what you did. So whether you corrected or did not correct, and which way you corrected, the end result was the same. So they concluded that there is no difference whether we correct or do not correct, irrespective of the method of correction. So another group of authors more recently went a step further. They took even more traumatic LPs, more than 10,000 RBCs, present in this thing. They took 20,000 lumbar punctures, median RBC count close to 50,000, visibly blood tinged, no doubt about it. They did exactly the same exercise and they came up with exactly the same result. It does not matter whether you correct or you don't correct and what method of correction you use. So then why bother to correct? So even the nice UK guidelines now say that there is hardly any difference, so don't correct for RBCs and traumatic LPs. So you might say that, our sensitivity may be dropping and all that. So the point is that for a disease like meningitis, you cannot afford to lose sensitivity. The more you correct, the more you lose sensitivity and gain specificity. So that's why your area under the ROC curve gets balanced, you get the same result finally. So the more you correct, the more you're likely to miss a diagnosis of meningitis, which is not acceptable. Next is, how much time does it take for an abnormal CSF parameter to normalize after starting antibiotics? So this is a very interesting study, again published by Greenberg in 2011. So they took all those who initially had abnormal CSF parameters and whose CSF culture cleared off in a repeat lumbar puncture. Why these repeat lumbar punctures were done, God alone knows, because they took it from an administrative database. But remember, keep it at the back, there must have been a reason to do a repeat lumbar puncture, which means they were not, kids who are your garden variety of neonatal meningitis. So just something to keep in mind. So this is the result. So these are all Kaplan-Meier curves. So everyone is starting off with 100% being positive at baseline. And then how much was the clearing or normalization as time went ahead. So this was not a planned prospective study. As and when clinicians decided that, a repeat lumbar puncture is required for whatever reason, that was recorded and then it was fed into this thing and a Kaplan-Meier curve was constructed out of it. As I said, no ethics committee will allow you to keep doing repeated lumbar punctures. That's a big problem on the same baby. So what was found was that with culture, the median time to clearance is about 4 days. By 4 days, the CSF culture becomes sterile once you start sensitive antibiotics. With glucose, it takes a fairly long time. See, it's here 20 days, 40 days, 60 days for glucose to completely normalize. For protein, it takes even longer. I mean, you're starting off with all those at an abnormal protein. Look at the time it takes for a positive finding on lumbar puncture to actually normalize over time. And similarly with WBC, it takes time from it to normalize, even though you're giving sensitive antibiotics. 2 lessons to be drawn. A, it takes time for parameters to normalize. Protein takes the longest, followed by WBC, followed by glucose. Culture, however, turns negative quickly. So, and in the initial days, first 4 to 7 days, there is in fact hardly any change in the WBC, glucose and protein. So what is the implication for clinical practice? The implication is that you can do a lumbar puncture even after a few doses of antibiotics. So just because, baby was sick, you avoided a lumbar puncture, is now 3rd, 4th, 5th day. That's no excuse for not doing a lumbar puncture. You will still get information from at least WBC, glucose and protein. Culture will become false negative, but these 3 will still hold on. Secondly, don't use these parameters on a repeat LP to judge improvement because they are going to remain abnormal for maybe weeks to come. So you do a repeat LP It is now the second week of the thing. You say, oh my God, there's still hypoglycemia, I must change my antibiotics, baby is not improving. No, they are going to remain abnormal for some time. So that's a very important message from this. So we asked ourselves that if all these tests are actually so mediocre, is there any other inflammatory marker in the CSF that can have a role in diagnosis? And we first targeted procalcitonin because procalcitonin is now fairly widely available in a lot of centers apart from CRP. So we did this study which was published last year in the Journal of Pediatrics and Child Health on procalcitonin. Basically, we defined the gold standard as CSF culture positive or gram state positive or CSF universal primer PCR positive. So any one of these three would make it a definite diagnosis. And we took 392 patients out of, after excluding, we were left with 209 patients. So that was our sample size. Of them, CSF procalcitonin were 97 were positive, 112 were negative. And the reference standard of these 97 so-called CSF procalcitonin positive, meningitis is actually proven in only 12. Whereas in those who are negative, as many as 6 had meningitis. So what did that leave us with? It left us with CSF procalcitonin, area under the ROC curve is only 0.66. Remember, the maximum is 1. The closer that value is to 1, the better is the test. You're looking for areas under ROC curves of around 0.8, 0.9. So 0.66 really does not, excite anybody. Although the p-value is significant, but it doesn't really mean much for a clinician. CSF to plasma procalcitonin ratio even worse. We derived a cutoff from our own ROC curve, which is 0.55, and using our own cutoff, we tried to calculate sensitivity and specificity, something that is actually not recommended to use your own cutoff on the data. But even with that, our sensitivity was only 50%, which is like tossing a coin. So CSF procalcitonin is as good as tossing a coin. And when you looked at definite or probable meningitis as the outcome, again, nothing very impressive, 0.64 and 0.48. So we concluded from this study that the area under the ROC curve of procalcitonin is too low to be of any discriminatory value to differentiate between meningitis and no meningitis. So finally, we asked ourselves this question, okay, nothing seems to be, it doesn't seem to be heading anywhere, all the standard tests, inflammatory markers. So is there a role of PCR and DNA sequencing in diagnosing neonatal meningitis? So this was part of a big DBT project, which is still unpublished. So I'll just walk you through a little bit about how this PCR thing is done so that you're all oriented to it. So this is the bacterial 16S rRNA gene, which is usually targeted for doing PCR. This is the gene. So it starts from this side, goes up to the end here. And in that gene, there are regions called V1, V2, V3, etc., going up to V9. These are known as the variable regions. Those are the dark blue. And the light blue in between are what are known as the conserved regions. They are called conserved because they have remained unchanged throughout bacterial evolution. Right from the time bacteria emerged 3.5 billion years ago, these have more or less remained unchanged. So all bacteria have them. So you can now have universal primer PCRs. That means primers which are targeting these highly conserved regions, and they will detect all bacteria. So there will be an intervening portion between two conserved regions where there will be the variable regions, and that variable region sequence helps you to tell which bacterium it is. Okay, so that's the whole game of this universal primer PCR. So what we did was in this study, we took 4 pairs of primers. So these are called forward primers and reverse primers. And they targeted, as you can see, different variable regions in the 16S rRNA gene with the product, PCR product, number of base pairs being shown here, roughly around 400 base pairs, each of these products. So we enrolled 206 subjects. Our reference standard was CSF culture or gram stain positive. We ended up with 16 of those, and the remaining 190 were reference standard negative. Now, how did this whole workflow for this study go? I'll just show it to you so that you know what we did. So initially, when we were standardizing the process, before we actually started recruiting patients, so we had known sterile CSF known cultures in culture plates in the microbiology lab. We spiked the CSF with known cultures in serial dilutions. That means, so that we had CSF samples, we now had 1 bacterium in it, 10 bacteria in it, 100 bacteria, known things. And then we extracted the DNA. From that DNA, we did a real-time quantitative PCR. This is an example of an amplification plot from real-time PCR. Using that real-time PCR product, we further amplified it using conventional PCR. And that was because conventional PCR is able to give very crisp bands of the amplified template, far more than what real-time PCR is able to do. So that's why it's very good for sequencing. So we then use a DNA sequencer to sequence this product. It generates something known as a chromatogram. So these, different colors. Each color represents A, C, T, or G in the 4 nucleotides. And once you get that sequence, you match it against published databases. One of them is called BLAST, which is available through NCBI, the same organization in which you get your PubMed. So they have this huge database. So you match that chromatogram against known sequences, and then you find out which bacterium it is, right? So you identify which microbe it is. So that's what we did. So this is a representative, plot of this universal primer PCR. So you can see here, there are some which have gone up. These are 3 positive patients with positive results on the universal primer PCR, and there was always a positive control run with each of these. So this is how we detected who all were PCR positive. So this is the result. So universal primer, real-time PCR on CSF diagnostic performance. So we found that there were reference standard positive were 16. All the 16 had been picked up by PCR. Reference standard negative were 190. Amongst those, 2 more were being picked up by PCR, which had not been picked up by culture and gram stain. And of all those who were PCR negative, were also reference standard negative. So from this, our prevalence was 7.8%. So just remember this figure, because this is a very carefully done study. So in India, neonate being suspected of sepsis was roughly 8%, that 5 to 10% chance of it being meningitis. The sensitivity was, of course, very high. It was 100% sensitivity because it didn't miss a single patient. And it was the reasonably narrow confidence interval. The specificity was 99%, 96 to 100% confidence interval. So a whoppingly high positive likelihood ratio, because both these are so high, and extremely low negative likelihood ratio, like very impressive positive and negative predictive values. So it seems to be a good thing. So then we went ahead and did the sequencing of these PCR products. I don't know whether you can all see it at the back, but this is just a representative, output being compared against a published BLAST database. And this is how we proved in this particular patient that the Acinetobacter baumannii got through DNA sequencing, matched the CSF culture report, because in CSF culture also we had grown Acinetobacter baumannii. So this is a summary of the sequencing results. I don't want you to read everything. So these are serial number 1 to 18. So there were 18 who were PCR positive. The green highlighted ones is where there was a discordance between the PCR and the culture report. So there were 2, these red ones, who were negative on CSF culture, negative on CSF gram stain, no negative blood culture. But in one of them, we grew Staphylococcus, we showed Staphylococcus aureus on DNA sequencing. Another one, we got E. coli on DNA sequencing. There was a third one in which there was a discrepancy between the species. We got a different thing on culture and a different thing on DNA sequencing. I told you there were 4 sets of primers, forward and backward. So 68F, 341F, 799F, and 967F. You can see the yeses here. Yeses means there was complete concordance in what we grew and what we got on sequencing. So in 3 of these primer sets, things were fine. There was this third primer set, targeting the V5, V7 region. There was a lot of discrepancy between culture and DNA sequencing. So what we concluded was that primer pairs targeting the V5, V7 region of the bacterial 16S RNA, they don't seem to perform very well. Targeting other regions, they're performing well. Now we also looked at those 3 patients with discordance, because we wanted to know, are these false positive on DNA sequencing, or is it truly they have picked up something? So we looked at the cell counts, CSF, protein, procalcitonin. Anyway, I've told you was not a very great test. Their clinical signs. I mean, there was nothing very convincingly telling us that these were sort of definite true positives. So we were still left with some ambiguity. So there is still some uncertainty regarding the positivity of these extra 2 patients that we got on PCR and DNA sequencing, but perhaps it is picking up a little more than what it is at least picking up what culture is picking up, perhaps a little more. So how long should we treat with antibiotics? It's always an important question. So I was chairing the National Neonatology Forum Clinical Practice Guidelines for Sepsis, and this is one of the questions that we tried answering in 2024. Unfortunately, there's hardly any data in literature. Of 8 citations shortlisted to review, only 1 could be included in the systematic review. This was by Professor N.B. Mathur, published in 2015. And even this study was a very small study, high risk of bias. And for some peculiar reason, they compared 10 versus 14 days of antibiotics, whereas the standard of care is usually 21 days. I don't know why they chose 10 versus 14. And in any case, it didn't really yield anything. It was all inconclusive. So finally, we as a group, the NNF group, made a strong recommendation against the use of any short course of intravenous antibiotics till better data is available. So we are stuck with this 21 days, although the 21 days is, again, just a figure plucked out of the air. No evidence to tell you that it should be 21. But that's been the norm, so you keep using it. So summing up, there is no low-risk subgroup in which you can avoid doing an LP. We obviously need better tests than CSF, WBC, protein, and glucose. If they're normal, they're good enough for excluding, but if any of them is positive, there is only about a 48 to 50% chance that it is meningitis. The rest is actually not meningitis. You're just treating it as meningitis. But damaging the neonate's microbiome, causing antibiotic resistance, whatnot, by over-treating for 21 days. It's not a short period. A delay in analysis alters CSF, WBC, and glucose. So it's a good idea to have a side lab, and I was very happy to see Dr. Mala showing a picture of a side lab, and Dr. Shalini, I believe, looking through a microscope, Sakshi looking through a microscope, and that's a good practice to do it right there at the bedside. And there is no advantage in correcting for the presence of RBCs and CSF. A point of care test can be done for CSF glucose using a blood gas machine. So try it out next time you take a CSF sample. A point of care dipsticks has very modest performance. I won't recommend it. Procalcitonin clearly does not help in diagnosis. Universal primer PCR and DNA sequencing probably is the way to go in the future. Obviously, this facility is not available everywhere because it is very high sensitivity and specificity. Antibiotics rapidly turn the culture sterile, but the other parameters may take a long time to normalize. So if you're unable to do an LB before starting antibiotics, which is a very common situation clinically, do try to do it within 3 to 4 days. You will still get useful information. But in case you're repeating an LB for some reason, don't rely on the non-resolution of the parameters to judge non-response and use that as an excuse to further continue antibiotics more than even 21 days. 21 days is bad enough. And for want of any information, continue 21 days, reluctantly, you have to give that recommendation with nothing to base it. So we are still sailing on very choppy waters, and there's a lot of work to be done in neonatal meningitis, but hopefully the lighthouse of research will someday guide us through this tempest to distant lands and distant shores where we'll have better information to guide us. Thank you all very much. Thank you.
Thank you, sir. So just one word for sir, it was mesmerizing. So clinician researcher par excellence. Thank you, sir. Thank you. Now I would like to invite Professor Chandrakanta to introduce the next orator.
It's my proud privilege to introduce Professor Monica Juneja ma'am. And she is currently Director, Professor and Head of Department of Maulana Azad Medical College, and it's also in charge of Child Developmental Center and Center of Excellence Early Intervention Center at the Associated Lok Nayak Hospital, New Delhi. She did her MBBS from UCMS and MD Pediatrics from MAMC New Delhi. And she is one of the pioneer in the field of developmental neurology. She started CDC in early 2001 at MAMC and has more than 25 years of experience in developmental pediatrics and child neurology. She pioneered the diagnosis and multidisciplinary management of autism in India, and she has written many chapters on developmental disorders in various books and has many research publications to her credit. She has won many awards, including International Excellence Award for Services to Children with Disability, PN Taneja Oration of DIAP, and Honorary FIAP of Disability Chapter Programs. So she is going to deliver late Professor Anand Sharma oration, and she will be talking about her journey in autism spectrum disorder. So we were eagerly waiting her to meet in person, but unfortunately she could not come, and she has joined us online. So I welcome Professor Monica Juneja ma'am to deliver her oration.
So, good afternoon, everyone.
Good afternoon.
Is the presentation visible?
Yes, ma'am, it's visible.
Okay, so before I start my presentation, I would like to thank Dr. Mala for inviting me for this oration and giving due consideration to my mother's illness and acute sickness, allowing me to deliver this oration from my home. So thank you so much. And I was listening to Dr. Saurabh Datta. It was an amazing presentation, loaded with so much information that our PG residents would be really amazed and mesmerized by the presentation. However, my presentation is somewhat much more lighter. I just wanted people to be sensitized to the diagnosis of autism from what I had started to the current situation. So it is not loaded with information, but it is what my journey is in this field. So I think residents would probably be more relaxed in listening while listening to this presentation. But I would still request them to wait till the end, because my aim is to motivate people to make the early diagnosis and focus on early intervention, because I would show one or two videos of our patients showing remarkable improvement, and I think that would give hope to everyone in the field. So without wasting any more time, let me start my presentation. So I have divided my presentation in mainly three domains. First was pertaining to the diagnosis of autism. My journey in diagnosis of autism started way back in 2000, 2001, when I had started this child development center at MAMC. And then one of these days, we saw this child being brought to us from a village from UP, and we were all surprised. I had only 1 or 2 PGs with me that time and a speech therapist and a staff nurse. So we were tuned to making a diagnosis of CP. That is what CDC was all supposed to be about. And this did not seem to be like CP at all. We were wondering what it was. Then a few weeks later, we got another one of these. So this child was more clearly looking aloof, self-absorbed. You could see that the grandmother of this child, who's the primary caregiver, is sitting behind him, and he's not bothered at all whether she is around or not. So this was one case which gave us some hint whether it could be autism. Now we went back to our book. The textbook of pediatrics at that time hardly mentioned anything about autism. It was there was only one page about psychosis in childhood, early onset autism, which is known as infantile autism. And there were hardly any trained professional who we could refer the patient to for making the diagnosis. So there was no option left. I started doing literature search for relevant articles and then understood that DSM-4 TR was the one which was available. That manual described the clinical features and how to make the diagnosis very lucidly. And still, it took me 6 months to 1 year to understand the clinical features properly. And after thorough understanding of this, we came up with a performer for diagnosing autism in our center, because we all understand that postgraduate residents come for managing and understanding these cases. So the easier way was to make a performer so that it became structured. In this, we documented all the features which were supposed to be documented to make the diagnosis and what meant by each feature, so that the postgraduates and senior residents who had no idea could at least start understanding what is autism about. And after a few years, we had few children, around 51 children, whose data, retrospective data, we published in this study, which was a descriptive hospital-based study of children with autism. And in this, we had mostly severely affected children with autism. That time, we were able to make the diagnosis or in only those severe ones. So if you look at it, in 2001, we could start making diagnosis of classical cases of autism. Then in 2004, I was able to design a detailed autism performer. In 2007, there was a Delhi High Court order looking at the prevalence of autism or diagnosis of autism as a result of a PIL formed by somebody whose child was diagnosed with autism in UK, but there were no facilities available in India. So as a response of that, the Delhi High Court had asked for the numbers or diagnosed ASD cases all over Delhi. And at that time, our center was the only one which had records of diagnosed cases of autism. And therefore, I was made amicus curiae, and I was given the responsibility of organizing multiple trainings for doctors all over Delhi. And after this training, we started seeing the number of cases being diagnosed with new autism, which these are the new cases which we were picking up, rise significantly. Based on what we were using in our Center for Diagnosis of Autism, in 2010 and 2014, between this period, as a part of INCLIN study, I developed the INDT ASD tool, and we could standardize it in 4 centers and validate it. And finally, the government of India approved this as a tool for making diagnosis all over India. Now, after this, the number of cases again increased significantly. And these numbers are actually not the real picture, because our numbers get restricted because we are focusing also on the intervention and follow-up of the already diagnosed cases. So new cases cannot be adjusted till we have slots for that. Anyways, the number of cases started increasing. Over the years, we also realized that the severity of children being diagnosed in our center had got modified. Initially, the mild cases would comprise only 34% of cases, and by 2023, they would comprise almost 50% of the population which we were diagnosing in our center. And this was all related to the not only the our skills development and improvement in our skills, as well as the parent awareness and the awareness in the community of the doctors and other specialists. So while we were focusing on the diagnosis of autism, we also realized that these children have many comorbidities, and then we did many research studies looking at these comorbid conditions which were there in these children, and that increased our knowledge, in-depth knowledge about these comorbid conditions in these patients. So we looked at epilepsy, the association with sensory problems, feeding problems, sleep problems, and since gluten-free, casein-free diet was commonly being used, we also looked at the association between celiac disease and autism spectrum disorder, and found there to be no association, at least with the celiac disease. Now we looked at so I just wanted to highlight some feedback letters from our patients, which can tell us that how they are having more hope now regarding the diagnosis of their child at least. So this was a mother of 14-year-old child who was brought to our center with academic difficulties and stubbornness. But in-depth interview also revealed that mother was much more worried about her discomfort regarding the child's inappropriate, apparently sexually laced behaviors towards her, for which the mother herself would blame herself and would often beat up the child because he was touching her inappropriately. And once the child was evaluated in detail in our center and the diagnosis of autism was made, and it was explained to the mother that it was not probably sexually laced, the child didn't have social limitation, did not understand where to touch and what not to touch, and it was the sensory issues which were guiding his touching behaviors. So her guilt and issues became somewhat less. There was another father of a child who was around 16 years of age who came to us from Chhattisgarh. Again, this child had significant academic issues and hyperactivity apart from the social skills issues which parents were not so much worried about. So as a doctor, the only explanation and the knowledge that they had about the developmental problem was ADHD, and that was what they were thinking that their child had. But still there was something nagging behind in their thought process that it is not explaining everything, and they consulted many experts regarding this and visited institutes all over the country. Finally, when they came to us in CDC, we could make the diagnosis of autism spectrum disorder, and that even though the diagnosis shook them to the core, they gave them a sense of closure because now they understood that majority of symptoms of their child could be explained by this diagnosis. So this was about our journey in the diagnosis of autism. Let me talk about in brief about our intervention. So when initially, this is the child who was around 3.5 years of age. Again, very severe symptoms. And we made the diagnosis, but where to treat the child, how to manage the child. Now, as a pediatrician, we just don't leave children with just the diagnosis. We want to treat the child as well. So we referred this child to some very well-known NGO for intervention, but they refused to take the child, stating the fact that they don't think the diagnosis can be made in children below 5 years of age, and they were not managing any of these children. So we were left on our own again. So what to do about it? Now, again, we had to go back to the literature. We purchased some published intervention programs like Teach Me Language and ABA, and went through those programs in detail. But we understood that these are very structured intervention programs and it will be difficult to implement in Indian settings. So after reading all this, then we had no option but to try various intervention by trial and error. And finally, we realized that parent-mediated intervention is a feasible and effective option. We started seeing changes in our children and everything being done by the parental training, and the children started showing changes. So we published a study in 2012, in fact, which showed that there was a significant change in the developmental profile, language, even and autism severity in these children based only on parental intervention. Now, in 2013, we had the opportunity to get trained in the one of the most popular program and well publicized and with documented efficacy, which was Early Start Denver model for providing intervention to these children with autism. And we had three international experts who came to us, our center, and trained our staff in this highly recommended Early Start Denver model. Now, in this model also, we understood that it is an intensive primary therapist mediated program, and which would really not be suitable for our settings. We don't have those many trained personnel who would be able to deliver these interventions to our patients the numbers are huge. So what we did is we adapted the principles of this program, customized it to our settings, used our own experience, and developed a transdisciplinary and parent-mediated intervention. And as a part of ICMR funded project, we developed this caregiver-administered holistic autism management program for individualized and optimal intervention, which we gave an acronym Champions Model for MAMC. Now, in this, we treated children between 2 to 6 years of age, newly diagnosed children with autism, and gave them intervention, again parent-mediated, and after 1 year of intervention, documented the change, and the change was remarkable. As you can see, many of them were showing a change in DQ of almost 20 points, and this is a remarkable change over 1 year. And the autism severity also scores change by significantly decreased after 1 year. And this is a remarkable change. You usually don't see this much change in younger children, especially based on the parental intervention. So subsequent to this, we got opportunity to publish some literature or research publication in the Lancet, as well as our champion model. This is in brief about our Child Development Center, how we are trying to change the parental lives with our intervention. Few interviews.
मैं यहाँ पे 2016 से आ रही हूँ, और जब से मैंने यहाँ दिखाया, मुझे इधर उधर कहीं जाना नहीं पड़ता है। मैं एक ही छत के नीचे मुझे सारी फैसिलिटी मिलती है। बच्चे में बहुत इम्प्रूवमेंट हुई, और इम्प्रूवमेंट में बच्चा अब स्कूल में भी आराम से बैठ जाता है। मैम की कंप्लेन हुआ करती थी कि ये बच्चा बैठता नहीं है, सारा दिन भागता रहता है, लेकिन अभी थोड़े टाइम से ये बच्चा आराम से बैठ जाता है थेरेपी के बाद, और मैम की भी कमांड फॉलो कर लेता है, हमारी भी बात मान लेता है, और गेम्स भी खेलता है, बच्चों के साथ इन्वॉल्व होता है, गेम्स खेलता है, और खेलने भी जाती है, नीचे उतरती है, समझ भी आता है, घर पे भी उसे लूडो वगैरह खेलने की कोशिश करती है, तो थोड़ा थोड़ा से समझ आता है, सांप-सीढ़ी वगैरह खेल लेती है, और जिद करती थी उसको काफी सारा, मतलब समझ जाते से समझाते हैं, बेटा ऐसे जिद नहीं करनी, ऐसे मान जाओ, ऐसे मान जाते। तभी यहाँ आने से ना बहुत इसको फर्क पड़ा है, और एक सारी सुविधाएं एक जगह पे मिल रही है, बहुत अच्छी बात है। काफी इससे पहले बहुत इम्प्रूवमेंट। चलिए आप कुछ इससे बहुत
This is another video of one of our students.
Papa? Papa? Ayat?
That was there were some videos about how intervention can change the lives of these children, especially in younger children. In early infancy, the results are remarkable. A few words about autism diagnosis in adolescents and those with normal or superior intelligence. And in these, we also again had to use an unconventional approach. We were focusing on, our focus has always been on developing help-seeking behaviors with social interaction. The child should be able to communicate their anxiety associated with social settings and building peer relationships. And for this, sometimes we had to show them some movies which were made on subjects with autism, discuss with them, tell them stories about what actually autism is all about. And once the children start getting an insight about these things, they themselves start understanding how they can modify their behaviors, what can be done by them, and how the family can support them in improving in social situations. So this is again about that mother who was worried about the inappropriately sexual behaviors of the child. We understood that by just having highly intelligent child does not mean that the child will automatically understand what are the appropriate behaviors in social situations, especially, and how to guide those development of those behaviors as per the intervention and suggestions that were made by our therapists and our team. And with intervention, not only the child is better, but the mother is also more confident about how she would be able to manage the child in the current situation and how she can target those behaviors in future, because now she understands what are the usual areas which are impaired in these children, and she's sensitized to the red flags which she has to keep in mind whenever she's looking at the child's behavior. So counseling and understanding and making the diagnosis makes a lot of difference, especially to these children's families as well. Now, the third area that is significant a problem, special even now, is the stigma associated with autism. So when we started, we now still also we see that when the diagnosis is made in these families, there is a denial. In fact, with all these behavioral issues and severe problems, the parental dispute comes up in a big way. The joint families and the larger family members may also not cooperate with the diagnosis and intervention, and many times mothers stop from coming to the centers, especially if the child is high functioning and the families would believe that the child is normal. Why do you want to take the child to a center like this? So there were family issues. There was a stigma associated with the child's behavior, and amongst peers also there would be a lot of bullying. These children would be avoided and they would feel left out. And that leads not only to academic issues, but also anxiety and depression. So many of our children who are presenting to psychiatric department or to us also now with depression and anxiety have underlying autism spectrum disorder, which was undiagnosed. Until it is picked up, the intervention is not holistic and the whole issue is not targeted. Now at school also, once these children were admitted because of their obvious behavioral abnormalities and much more social issues, when they don't understand how to behave in school, there were problems with admission. There were problems in inclusion of these children in various activities. Even though the child was admitted, they would not be involved in the social and sport activities which were being organized in the school. And the community's exclusion, obviously, we all understand. In fact, many would question the parenting of these families, that they don't know how to discipline their child, and that is why the child is showing these tantrums and these obviously abnormal behaviors in the community. So we focus on awareness and acceptance, focusing on family counseling as a whole. So for this, we would try, though it is not always possible, to not only call both the parents, but also the grandparents and other people who are the main what we call head of the families who make the decisions and are very important in decision making in the family. The role of media is very important. There were awareness campaigns organized not only by the NGOs but by government organizations and private organizations as well. And disability certification. The advantages of now getting disability certificate, helping them not only in getting school admissions but also in other prioritized areas, has increased the acceptance of this diagnosis. And obviously now parents want these certificates because the problems are quite obvious, especially in the severe ones. This is one of our
उसके बाद स्कूल भी चेंज किया बच्चे का और एक्सेप्टेंस वहाँ पे मिलता है बच्चे को.
So now she is able to get the child admitted in a school and where there is acceptance of the diagnosis. So once parents understand the diagnosis, they know what to do with the child and how to train the child. And if the teachers know the diagnosis, many a times they also ask for help and they try to modify their way that they are dealing with these children and how they are making these children learn. Because there might be issues not only with the intelligence but also the way these children learn. So all these things affect the quality of life not only of the child but also of the sibling and the families, and we have done some studies related to quality of life of these children and their families. That has increased our understanding of what are the factors which are affecting their inter-family associations and relationships and how we can help the family as a whole. So the woods are lovely, dark and deep, but I have promises to keep, and miles to go before I sleep, and miles to go before I sleep. So these are famous lines by Robert Frost, and though we have achieved a lot, but I know there is a lot more that we can be achieved with these children, and we can make them very adult contributing members of our society who will achieve a lot for our country. We all understand that Albert Einstein was probably a person with autism, and the way they look at things probably is different, but then that is the way the society and the science may also change. So instead of now being totally spared, I have hopes for these children and the society as a whole. So with this, I would like to thank all of you for a patient listening. Thanks a lot.
Thank you, ma'am. It is so heartening to see satisfied families. Thank you for these exceptional services being provided through your CDC. I would now request Professor Rashmi Kumar, madam, to confer the oration to Professor Monica Juneja.
How will madam be visible?
Can you see me, Monica?
You can go on the
Yes, I can see you.
So
the side profile, but thank you so much.
That's Rashmi madam.
Yes.
So I'm just
We have met previously. Many times I had visited Lucknow when she was the head.
Look towards the camera, madam. Then you. Okay, yes, this is the camera.
So this is the plaque that you're being conferred with. And that's a stole for you. Yeah, that's a stole for you.
Thank you so much.
Sent to you by courier.
Yeah, thank you. I hope you enjoyed the talk. It was a light talk, not so much loaded with the technical information, but I think sensitization was important. And it is an honor to receive the oration award from you. Thank you, Dr. Mala. Thank you so much for inviting.
Thank you so much. Thank you.
Can I leave now?
Yes, ma'am. Yes, ma'am.
Thank you. Thank you, Lord. We can take a picture. We can take a picture. मैम इधर आ जाइए ये इधर everybody is full of PCRs and autism and everything. So Arisha भी आ जाओ.
प्रोग्राम में तो जाते हैं ना more than 45 minutes नहीं बैठना लगा के बाद
अभी है 5 मिनट के बाद and photograph break. और एक मैम की फोटो एक मैम को देना.
I would request Dr. Sanjeev to please felicitate our retired teachers by giving them plants.
He's there in my just about to start having lunch.
ये मेरे को थोड़ा सा ये तो फिर नेक्स्ट स्लाइड होगा ना। ये बैक साइड ये वाला क्या अप डाउन ये भी स्लाइड के लिए इससे भी चलेगा। अच्छा ठीक है और स्लाइड चेंजर लगा दूं क्या इससे इसमें है स्लाइड
ये तो खत्म हो गया हम लोग को बोलना पड़ेगा क्या?
बिना बोले थोड़ी आने देंगे आप ऑडियंस रहेंगे जहाँ ऑडियंस को पढ़ने तो ये शायद ये होगा ये हो गया पॉइंट ये लाइट वाला है इससे एरो को इससे ये तो ये ही पॉइंट ये पॉइंट आगे पीछे मेरे क्या एनिमेशन से ना वो थोड़ा सा इसलिए चलिए सब लोग बैठ जाए फोटो लेते हैं
I see all updates on the different रेडी सर
देख लेना नाम फर्क है थैंक यू
वो सब आ थैंक यू
She is one of the first people to start a clinic like this. You know, I remember once these people came
मोबाइल पास कर मोबाइल दे दीजिए आपको तो फोन चाहिए दे मैम
इसको 3 केसेस child behavior change and then choose to go further and go proper.
So after the two orations, now we have two more talks. For the first talk, I would like to invite Dr. Sarika to introduce the speaker.
Thanks, Dr. Nishan. So for after this short break, now two talks. So for the first talk, it gives me immense pleasure to invite Professor Rashmi Ranjan Das, and he is professor at AIIMS Bhubaneswar, and his area of interest is pediatric pulmonology and intensive care. And in the morning, we listen to teacher because was in 19 serve IPA, a lot of data there. 3 books edited and 25 book chapter. So please join me to welcome Dr. Rashmi Ranjan Das.
So which is ये वो था ना non-split. I think non-shape this one.
Respected Professor Malakumar, Professor Rasmi Kumar, Professor Archana Kumar, Professor Chandrakanta, Professor Sarika Gupta, Dr. Nissan Verma, and all the faculties and my dear residents. It's a pleasure to be here, and I am really indebted to Professor Malakumar, HOD Paediatrics, and Professor Sarika Gupta for their kind invitation to deliver this lecture on 71st Foundation Day of Department of Pediatrics. Your department is really amazing, and I was quite impressed to see all the achievements, the visions you have. So my best of luck to all of you, and I'll be happy to see if more subspecialties start the DM course in your department. So my best wishes. And as Dr. Sarika was telling, so you heard in the morning talk by my teacher and my co-guide, Professor Saurabh Datta. And Sir is a really good clinician as well as a researcher. And whatever research we have learned or the whatever interested regarding research was generated, it was because of him only. So I was kind of really overwhelmed to share stage with Sir. Sir has left for airport, but I hope he could have listened to my talk and kind of be with. Okay, he's taking, yeah. So today I'll be delivering a talk on a very important topic, that is the non-cystic fibrosis bronchiectasis. So if I tell, this term is now a misnomer. Why? Because when this term was coined, the point was to differentiate these two types of bronchiectasis. One is CF, second is non-CF. Why? Because you know, the signature organism in cystic fibrosis is entirely different. So Pseudomonas, Staph aureus, Burkholderia. So these are the signature organisms, and the treatment is entirely different. So that was the point, it was separated. But in our experience and from couple of studies, we have seen that once the patient develops bronchiectasis, you can get similar set of organism like Pseudomonas, Staph aureus. So it doesn't mean that if you are getting this organism in the blood or the sputum or the bronchoalveolar lavage of any side, it doesn't tell that the patient is suffering only from CF. That means you have to rule out other diseases also. So with this, so this is the plan of my today's talk. So I'll be telling you some of the terminologies, when to investigate. That means which child should undergo testing for bronchiectasis. What are the etiologies? How this happens? What is the pathogenesis? How to diagnose? Some case snippets, because it is very difficult to discuss cases in a time limit of 30 minutes. So I will quickly navigate through 4 cases. And I'll be telling you what treatment you have to employ to treat children with bronchiectasis, and finally some key messages. So some terminologies. It is very important to understand the meaning of wet cough. Why? Because small kids, they cannot take out the sputum. Okay, so most of the time what happens, we are used to the term productive cough, but the children, they cannot take out the cough, so you have to tell that there is wet cough. So wet cough means when the sound is coming during cough only. It doesn't have any relation with the respiration. But if it has a relationship with respiration, then it is a noisy breathing. Okay, so that is the basic difference. We know we have 2 types of cough. One is dry, second is wet. Dry cough indicates there is irritation and inflammation of the airways. But wet cough indicates there is a superadded infection and there is a problem in the mucociliary clearance. So from the pathology point of view, if you score, the wet cough will be more pathological than the dry cough, because the wet cough is always abnormal. But dry cough may have some normal etiologies. Okay. With this background, let us try to understand some important terminologies like PBB, that is the protracted bacterial bronchitis. The second one is the chronic suppurative lung disease, and the third one is the bronchiectasis. So you see the entire spectrum. Okay, so on one end it is the PBB, and the other end it is the bronchiectasis. So what is the meaning of this PBB? Okay, so this is a very new term, and the first this term was or the disease was described in Australia. Okay, by the famous researcher Annie B. Chang, the world famous pediatric pulmonologist, And if you see the series about PPB, you will see many case series reports being published from Australia. But the true prevalence in India, nobody knows. So what is this PPB? Any well-thriving child having a wet cough for more than 4 weeks, and you give a course of antibiotic, that is amoxicillin, for 2 weeks, the cough is totally disappeared. Then you have to think that probably the child was suffering from PPB. Okay? Why PPB is important? Because it has been seen that children with PPB can develop CSLD followed by bronchiectasis. The second one is the CSLD, that is the chronic suppurative lung disease. So what is the definition? Any child with wet cough for more than 6 months. And if you do the imaging, there is no bronchiectasis. So child is producing copious amount of sputum. There is a wet cough which is lasting for more than 6 months, which is not getting cleared with the antibiotics. You have to think of CSLD. Here the CT is normal. The end spectrum is the bronchiectasis. So in bronchiectasis, same clinical picture will occur, but if you do the CT scan, you will get the bronchiectasis. So bronchiectasis is a radiological diagnosis. And if you see the spectrum, you can prevent bronchiectasis if you intervene till the stage of CSLD. Once bronchiectasis develops, it is always irreversible. Okay? So then we have to see the profile of children in which you have to investigate for bronchiectasis or CSLD. So as I told earlier, chronic productive or moist cough for more than 8 weeks or less than 8 weeks, but worsening. Okay, more than 4 weeks you give antibiotic, it got cleared, it is fine. But more than 8 weeks persisting or less than 8 weeks but worsening, you have to think of. Then asthma mimics. Okay, so all that wheezes is not asthma. That stands good. So any patient who is not responding to bronchodilators, your ICS, the cough is persisting. So those are asthma mimics. So in those cases also you have to try to find out bronchiectasis. Any patient having a localized problem, suppose there is a foreign body inhalation or there is some abnormality on the X-ray which is focal, those children have to be followed up for development of bronchiectasis. Then post-severe pneumonia. So any patient who suffered a severe pneumonia, the patient was in ICU, okay, and the patient got discharged, but still there is clinical findings persisting, the child is still symptomatic, the radiological resolution is not complete. Those children also have to be followed to see whether they are developing bronchiectasis. Any patient with recurrent and persistent pneumonia, mind it, any patient with bronchiectasis also develop recurrent and persistent pneumonia. So recurrent and persistent pneumonia leading to bronchiectasis, bronchiectasis also leading to recurrent and persistent pneumonia. Third is persistent and unexplained physical signs or radiographic abnormalities. Okay, so in the particular clinical context that you have to see. Respiratory symptoms with any clinical feature of cystic fibrosis, primary ciliary dyskinesia or IEI. That is the inborn error of immunity. So nowadays, the primary immunodeficiency term has been abolished. So it has been replaced by the term is inborn error of immunity. So whenever you are appearing the exam, you are presenting cases, do not utter the word primary immune deficiency. It is inborn error of immunity. Then coming to the etiology. So the etiology is myriad. And if you see in different series, let it be developing countries, developed countries, or underprivileged countries, the most common cause of bronchiectasis is idiopathic. Idiopathic doesn't mean that there is no cause. There is a cause, hidden cause, which we are not able to identify. So idiopathic. The second most common cause is the post-infectious. Any infection, like your severe viral pneumonia. And the notorious viruses are your measles, adenovirus, varicella, and you can tell there are some other viruses like COVID-19, I don't know, you might have seen many patients developing bronchiectasis post-COVID. Then pertussis, it also causes bronchiectasis, tuberculosis, okay? Though we are lucky enough to see these rare causes like post-pertussis, post-tuberculosis, but they are also important causes. Any patient having any unexplained severe necrotizing pneumonia is also at risk of developing this bronchiectasis. So aside these idiopathic causes, among the identifiable causes, you can divide them into two broad categories. The first one is the congenital genetic, the second one is the acquired one. So among the congenital causes, the important cause is the malformations. Okay, so among the malformations, the airway malasias like tracheomalacia, bronchomalacia, laryngomalacia. These are the diseases that increases the risk of bronchiectasis. Tracheoesophageal fistula, particularly the A type, laryngeal cleft, okay, and the pulmonary sequestration. So these are the 4 pulmonary abnormality that have the highest risk of developing this bronchiectasis. Then defective clearance of the secretions. Okay, there is a problem in the airway, so the patient is not able to handle the airway secretions. The cause, all of you know, cystic fibrosis, primary ciliary dyskinesia, alpha-1 antitrypsin deficiency. So these are the diseases. So any patient suffering from these diseases are almost at 100% risk of developing the bronchiectasis. Then inborn error of immunity. So related to B cell, T cell. Okay, so these are the diseases previously called as primary immunodeficiency. So your hyper IgE syndrome like Job syndrome, hyper IgM. So all these increases the risk of this bronchiectasis. And among the acquired causes, as I told earlier, so post-infectious. So already the infection that can cause, already I have mentioned, airway obstruction. Okay, the most common cause of airway obstruction is the foreign body. Besides the foreign body, any intraluminal or extraluminal compression. For example, there is a large lymph node secondary to tuberculosis, secondary to some infection, or there is a intraluminal tumor or mass, or there is a vascular ring which is compressing. So because of that chronic compression, so what will happen? That area, the secretion will remain stasis. It will get superimposed with infections, leading to localized bronchiectasis. Then allergy or immunological. Okay, so all of us know these allergic diseases like your ABPA, that is allergic bronchopulmonary aspergillosis, asthma, then autoimmune diseases. Okay, so these increase the risk of bronchiectasis. And among the secondary immunodeficiency, your chronic steroid use, your HIV. So these are the important causes. And environmental toxins. Okay, so like pollutions, this particulate material. So they will get kind of your size less than 2.5 ppm. So they will get deposited, and one can develop bronchiectasis long run. So you know our kind of AQI, that is the air quality index. Almost all major cities in India is kind of very bad. And even Bhubaneswar, you cannot imagine, Bhubaneswar in the coastal area, almost always there is a rain. Actually, rain clears it improves the AQI. But still the AQI of Bhubaneswar is more than 300 always, which is very, very bad. Okay, so there is no city, I think in next 5 years, where you will get cleaner air. So we may have to carry oxygen cylinder or the air cylinder with us whenever we are visiting any destination for our kind of merrymaking or whatever it may be. Pathogenesis, okay? So it may be host related, as we discussed, environment related or pathogen related. Already have discussed those. So what they cause? So they cause endobronchial infection. The very characteristic picture of all these infections that they are less virulent. If it is high virulent, it will get cleared with the antibiotics. But the infections which remain persistent and cause bronchiectasis are very funny. Like Streptococcus pneumoniae, which is less virulent. Your non-typeable Haemophilus influenzae, Moraxella catarrhalis. So these are the 3 organisms which will not cause pneumonia. Okay, there are some serotypes of Streptococcus pneumoniae. They will remain persistent. They will form a biofilm, causing persistence of infection, leading to localized damage. Okay, so all these factors, what they will do, they will cause persistent airway inflammation, airway obstruction, damage, dilatation of airways, and the airway hypertrophy, leading to impaired mucociliary clearance. So once the airway is dilated, there is a mucous secretion secondary to your inflammation infection. The small child cannot take out all the sputum. So some sputum will remain, and again the infection will happen. Okay. So all this will lead to finally mucus hypersecretion with or without increased airway hyperreactivity. So mind it, in bronchiectasis, initially the patient may respond to bronchodilator. It may not be complete, but there will be some good response. Any patient who was responding before not responding well, that means is the advanced stage of bronchiectasis. So whenever you are dealing with any patient who is not responding well to bronchodilator, it is a good idea to rule out underlying bronchiectasis or similar kind of pathology. Now, what are the clinical manifestations? So again, there are many. The most common, as I told earlier, the child will present with chronic wet or productive cough. If it is a big kid, he will take out the sputum. If it is a small kid less than 5 years, he will have this wet cough. and already have described what is the meaning of wet cough. Recurrent protracted bacterial bronchitis, okay, that is PBB. Recurrent or previous pneumonia, okay. As I told, bronchitis also causes recurrent or constant pneumonia, okay. Then which are reversible airway obstruction in the initial period, but later the child will not respond. Hemoptysis. Why? Because whenever the airway is dilated, adjacent vessel will also get affected because there is a traction bronchitis. So what will happen? This, because of this traction, the artery lumen will wire will become thin, and that will cause dilatation, aneurysm formation, and leading to hemoptysis. Chest pain, it is a very rare finding, classically seen in older children. The patient may have dyspnea or exertional dyspnea. Okay, mind it, because children who are having some problem, cardiovascular disease, cardiorespiratory diseases, they will restrict their activity. So when you tell as the parent, they will tell me, "Bachcha theek hai, wo khelta nahi, but otherwise he is fine." No. Then you have to ask why he is not playing. Any child who is not playing, who is not going to have some outdoor activity, that means there is some problem. But parents will know he doesn't go outside, he is a very calm child, he is a good child, he will remain at home. But again, then you ask why this is happening. Okay, that will indicate there is some restriction of activity. That also happens in case of uncontrolled asthma. Patient will not go out, he will not play, so he will behave like a good boy, less activity, less being naughty. So parents will feel that my child is okay, but he is not okay. Then sinusitis, otitis problem. So that classically happens in diseases with airway clearance problem, like primary ciliary dyskinesia. And in advanced bronchitis, there will be faltering of growth. The child will not grow well, he will become cyanosed, and then there will be decreased intake and feeding difficulties. Then coming to the signs, if you examine the patient with bronchitis, you will get digital clubbing. There may be chest deformity. So as the airway is dilated, there will be air trapping. Okay, so so what will happen? There will be expanded chest, and in advanced cases, you will get a kind of cylindrical chest. And you may get differential airway sounds. Okay, sometimes you may get crepitation, sometimes wheeze, or a combination of that. And you may also get crackles, which is coarse crackles. So coarse crackles occurs in two conditions. One is bronchitis, the second is which one? You can get coarse crackles. This is exam question. Pneumonia. So please remember, pneumonia, childhood pneumonia, consultation will have two types of crackles. One is fine and coarse. You got my point? But in bronchitis, only coarse crackles. So this is an exam question. So how to diagnose and what investigation you have to plan? Okay. First one, to prove the diagnosis. I told bronchitis is a radiological diagnosis. Because in CSLD, what will happen? Patient will have same symptoms. Copious amount of cough, there will be some bronchial reversibility, there may be some limitation of activity. But the imaging shows there is no bronchitis. So the investigation of choice to prove bronchitis is the radiology. And out of the radiology, it is the CT, that is the HRCT test, that is the gold standard. If any child with the kind of chronic wet cough, you have done the CT is fine, that means the child doesn't have bronchitis. So it almost rules out. Okay. And to prove the etiology, you have to do syndrome or etiology specific investigation. So you get the clue from the history and examination, then you tailored your investigation. Suppose child is having kind of chronic wet cough, failure to thrive, onset of symptoms in neonatal period, there is a delayed meconium passage. Okay, so you can think of, and there is an oily stool, so you have to do the sweat test. Any patient having kind of recurrent pneumonia, neonatal oxygen requirement with recurrent sinusitis, otitis media, you have to think of PCD, primary ciliary dyskinesia. I will tell two important things so that you will not miss or you will suspect PCD. Any patient having neonatal oxygen requirement, a Tom baby, required oxygen without any other cause, later developed recurrent pneumonia, very classical of PCD. Second point, a patient referred from ENT for hearing loss without any appreciable cause. There is a grommet insertion. Always think of PCD. This PCD patient, the most common manifestation is hearing problem. This conductive hearing loss because of recurrent otitis media. They may snore also. Recurrent persistent rhinitis. You tell, is there an allergy kind of? No. No sneezing, nothing, only nasal block and is snoring. Always think of PCD. So any child who is having persistent nasal block, recurrent otitis media, have been referred to from ENT with a grommet insertion or recurrent otitis media that is not getting cleared, or a neonatal oxygen requirement, always think of PCD. If you calculate the prevalence, PCD will be 10 times more prevalent than CF. But we don't have the diagnostic facilities, so we may be missing many cases of PCD. I teach my student, the number of pneumonia cases you see may be equivalent to that of PCD if you properly investigate. This disease doesn't manifest almost during the childhood period. So we are not bothered actually. Usually they manifest after 20 years commonly. Then to evaluate the airway microbiology, because the most important part of management of bronchiectasis, you have to clear the infection. When the patient is away from infection, the airway damage will not progress more. Okay, so that's why you have to always in the follow-up take out the sputum. Suppose the child is not take out the sputum, you may induce it, or you may do a bronchoscopy to take out the bag. Always see the organism, okay, and you have to clear that. Lastly, to evaluate the disease extent or progression. Suppose there is a diagnosed case, you want to see whether it is progressing, it is static, what is the rate of progression. You have to do repeat imaging or the lung function test. Okay, so these are the investigations you have to do. Something regarding the CT chest in bronchiectasis. As a pediatrician, we are not keen to discuss CT, but if you want to learn CT, whenever imaging is done, don't wait for the radiologist report. You take the films, discuss with the radiologist, and if you do it multiple times, at the end you will be able to report the CT. We also see CT, MRI, everything on our own because over the time period we have gained that expertise. This has so happened that the radiology resident missed one finding, but we could pick up the child had some problem, and they told it is normal, but it was missed. So this may so happen that. So it is not a very difficult job. So CT chest is the gold standard. So what findings may happen in bronchiectasis? If you see, these are the abnormalities. If you see, there is a plugged and thickened centrilobular bronchioles that is known as tree in bird sign. Mind it, tree in bird sign is not pathognomony of bronchiectasis. It can occur in all types of infection. Tree in bird indicate there is an infection, but classically it is described in your tuberculosis and bronchiectasis. Okay. Then you will get areas of decreased attenuation reflecting small airway obliteration. Okay, so if you see, this is the normal lung and there is a decreased attenuation, there is some decreased intensity. So probably there is bronchiolitis which is happening, that is the small airway inflammation. And this is the signet ring sign. I will describe in next slide. If you see, so this the white one is this is the your bronchus or the bronchiole, and this one, the more dense, the colored one is the artery. So if you see the bronchus there and artery, they are nearby. It is more dilated, almost 2 to 3 times that up. So this is showing a sign known as signet ring sign. In our pathology, there are so many causes of this signet ring sign. So bronchiectasis is also a cause of the signet ring sign on your this one, CT. Then non-tapping or clearing of bronchi. If you see the peripheral airways, normally the bronchi should not be visible. But if you are seeing some dilated airways, you think that there is a problem. Then crowding of bronchi with associated volume loss. What will happen in some areas, you will see the parenchyma, these are, or the bronchi are crowded. The patient may have some features of volume loss. 1, 2, they may be crowded. Okay. And you will get mucus-filled dilated bronchi known as phlegm and blob sign. Okay. So you will get this type of picture that the bronchi are dilated and there are whitish material inside it. So these are the CT picture of bronchiectasis. Something regarding the signet sign already I have described. So this is the bronchial artery and this is the dilated bronchus. So if you see in this image, so these are the signet. You see this is the bronchus, this is the artery. So this is the bronchus, this is the artery. So it is almost pathognomonic of this CT picture of bronchiectasis. So then coming to the recommendation, so which type of CT you have to use, okay? So this is the as per the ERS guideline. So whether it is HRCT or other type of CT. Previously what was happening, we do a CT which may be non-contrast or contrast enhanced. So CCT you do if you want to see the blood vessels, you want to see infective foci. NCCT if it is non-infective and you don't want to see the your blood vessels. HRCT you have to do whenever you suspect there is some interstitial problem. But when the child comes, you don't know where is the problem. So mind it, any child who is undergoing chest CT, always do a CCT. Why? Because it will give you all the informations. it will tell you the parenchyma, it will tell you the interstitium, it will tell you the your vessels. Your job is almost done. Okay, so they tell that another city is your city with virtual bronchoscopy. Suppose you don't have bronchoscopy facility, but luckily you have. It is because of effort of Dr. Sarika Gupta, your HOD, and maybe VC. So that is a very good kind of instrument to have in the department whenever you are dealing children with respiratory diseases. Okay, so if you want to see the foreign body, that is the only indication. CT virtual bronchoscopy. Okay, so they tell that instead of doing plain HRCT, you have to do the high resolution multi-detector CT with HRCT. Nothing to worry. Nowadays, whenever you procure any CT instrument, it is the MD-CT. Your 64 slice, 128 slice, maybe 356 slide. Like 56, we are very kind of fond of. Always we hear 56 from different sources. So 56 is a magic number. Okay. So this, so whenever you are bringing any, purchasing any CT instrument, it is MD-CT. So you have to write in your CT form, whenever you are sending any patient, that please do MD-CT with HRCT. Diagnosis is query bronchiectasis. So in that you will get all the pictures. Okay. So I told the bronchi are dilated more than the blood vessels. But what is the ratio? Always the bronchi are narrower than the lumen or diameter of artery. But if the bronchi is more dilated and the ratio is more than 0.8, so then you can tell it is bronchiectasis. So you cannot calculate. Of course, the radiologist has to tell that this is there and there is bronchiectasis. So then how to prove the etiologies? So always take a very good history. I tell my students, if you have taken very good history, 95% you reach the diagnosis. You do a examination, additional 3 to 4%. So if your history examination is perfect, almost 99% you will make the diagnosis or you will make a provisional diagnosis. But if you do the investigation first, the reverse happens. Only in 1% cases you will get the correct diagnosis. Okay, so that's why nothing can replace the history and examination finding. A very good clinician is kind of you can tell the ornament is a very good history, listen to the patient and do a focused examination. Okay, so post-infectious, you know, whenever the bronchiectasis is happening, the infection is gone. You cannot know. But suppose the patient has those infections already. I described like adenovirus infections, measles, varicella. He has suffered from pertussis, tuberculosis. And this child was normal, but now having a recurrent or persistent respiratory symptom. So that is one clue that probably those infections have happened. So we have a good number of cases post-TB bronchiectasis. We have 2-3 cases of post-measles, post-varicella bronchiectasis. And pertussis probably one, I forget. So probably one. So almost all type of infection we have seen. Adenovirus we have recently detected. So in next 5 to 10 years we may see new cases. Mucociliary disorder. So patient, what will have? The patient will have failure to thrive, a recurrent hospitalization, and you will get a signature organism in the sputum like Pseudomonas staph aureus. But these are not pathognomonic. But if you are getting, then it gives you a clue that probably the child is suffering from either cystic fibrosis or PCD. Immunodeficiency, any persistent or recurrent infection or severe infection at multiple sites, multiple organs, or infection with an opportunistic organism. Always think of immunodeficiency. Okay? And do not forget to see the tonsils. In 3-4 cases, my resident have forgot to saw the tonsil, and when we send the genetic test, it is Bruton's gamma globulin. So never forget to see the tonsils in all patients. Any patient having recurrent unexplained infection, hospitalization, always see the tonsil. Allergy fungal. So in a background of asthma, cystic fibrosis, any patient having recurrent persistent symptom, so it may be ABPA. Okay, and you will get relevant history in case of autoimmune disease. And if there is uncontrolled asthma, those patients may also in future develop this bronchiectasis. Rare condition, so history will give you the clue. Suppose the patient is having congenital malformation, foreign body inhalation, you will get the clue from that. To prove the etiology, already I have told you have to do the focused investigation. What you think, you do that. Okay, suppose you are not able to make some provisional diagnosis. Then you go in serial ways. You take the history, do the examination, do some basic blood test. Next line is do the imaging. Suppose you are not getting anything, only bronchiectasis, then you do the sweat test. Then if you have facility, then you can do test for PCD and send for stool fat globules, okay, and do some allergic test and look for ABP, okay, like that you have to go one by one. Suppose the patient is suffering from bronchiectasis, how to know that whether it's progressing, okay? So you can do imaging, but you know, if you do repeated CT, the patient will be exposed to radiation. So you can do the pulmonary function test. So I hope you have spirometry. So if you do repeated spirometry, you can see the rate of decline of this FEV1 and FBC. Okay, so these are the two important parameters. So if they're declining, that means the patient is having a progressive disease. Case scenarios, case snippets. Actually, you have to tell me the diagnosis. So please listen carefully to those case scenarios. Very interesting. An 8-year-old boy who presented with complaints of recurrent episodes of cough, fever, fast breathing for 3 years, already has taken ATD twice in past for clinical complaints and radiological opacities. There is no clear improvement in either clinical picture, and radiological opacities are increasing. So these are the serial X-rays, as you can see. So this is the first X-ray. If you see, almost it is looking normal to you, but if a pulmonologist see, so probably there is some hyperinflation on the left side. Okay. And the second one, more worsening. Third one, almost you see the apex is shifted towards right. So right volume loss is marked. Almost the right lung is totally bronchiectatic. Okay. So CT was done. It confirmed the finding. So there is a right lung total bronchiectasis now, which has progressed. Localized bronchiectasis. What is the most common cause? Yes. Excellent. Always think of foreign body. So if you see, there is a foreign body lying over here. So these are the volume rendered CT, CT virtual bronchoscopy. So it is the internally rendered. That means it will show you inside of the airways parenchyma. This is the external rendered. That means it will show outside part. Okay. I'm not going into detail. Already you have told. Please the diagnosis. Fantastic. Case 2. 12-year-old boy, cough with sputum and fever for 2 weeks. There is history of hemoptysis, 1 to 2 episodes, not large volume. No history of contact with tuberculosis. Sputum CV naught was negative, and Mantux was done. It is 14 millimeter. So now, are you doing this Mantux test for diagnosis? No, it is obsolete. There is no point in doing. Now it is a microvascular diagnosis. So this is the first X-ray done. Is it normal or abnormal? Which side abnormal? Both side or one side? Both side. So you see there is a dense consolidation like homogeneous opacity over here, and there is some areas of breakdown, almost kind of looking like probably some necrotizing pneumonia or maybe healed lung abscess. Okay. So CT was done. This is the upper part. So this is the trachea. So trachea means it is the upper lobe of the lungs. Okay. So that confirms that there is some consolidation over here, and there are some kind of, you see there are some pockets here. So maybe some secretions, whatever it may be. So now we have gone down, okay. So it is below the carina. That means the division of right and left main bronchi. And if you see that previous X-ray, so this is almost in the middle and lower zone. And that is matching over here. Middle means it is almost aborting the carina, and lower means it is downward. So if you see, there are copious secretions and dilated bronchi. Okay, here there is a bronchial dilatation. Okay. So this child underwent further investigations. All other tests was done, that was normal. But what is abnormal was the serum Ig was markedly elevated. And whenever any patient having chronic symptom, the serum Ig is markedly elevated. What do you have to think of? ABP, fantastic. All of you know that. So it was done. As per the Ig, IgG both were elevated. So treatment, the child was given short course oral steroid because the disease was active. He had a history of hemoptysis. Normally in quiescent disease, you don't give oral steroid. So itraconazole has, don't know, some people give, some do not give. But recently we made the guideline, that IAP-NRC ABPA guideline, in which itraconazole has not to be given. So you can give oral steroid followed by ICS. Okay. But if it is active infection, there is some problem, patient is running fever, something like that. That means there is active fungus residing. In that case, you can use. Otherwise, blanketly, we should not use itraconazole in bronchiectasis. Don't tell this to adult chest physicians. Always they give. So we should not fight actually. Yeah. So diagnosis already you have told. Case 3, 14-year-old boy, chronic weight cough since age of 1 year, having exacerbations in between, which is around 4 to 5 per year. Child treated for TB 2-year ban. And he was referred because of possibility of post-TB bronchiectasis, because TB is also one of the most important cause. He was admitted with active complaints. He had short stature, delayed puberty, wheezing was apparent. There was hepatosplenomegaly also. So every test was done that was negative. Bronchoscopy was done. Only some secretions were there. CT was done. So what is there in the CT? Now you should tell me. Bronchitis. Bilateral equal or which side is more? Right side. So this is the right one. This is the left one. So right there is more bronchitis. Okay. So left there is few, but right it is almost all lobes are involved. This is at the level of trachea. That means upper lobe. So this is below the coronary. That means middle and lower lobe. Okay. Investigation, all were normal. So immunoglobulin profile was done. If you see, all are low. CD3 also low, and CD8 borderline almost you can tell normal. So hypogammaglobulinemia and also T cell affected. What is the disease? Both B and T. SCID. Okay. So that was confirmed in the this one. That is whole exome sequencing. Last case, 12-year-old boy presented with complaint of chronic nasal obstruction, nasal discharge in 3-4 years. Examination, there was some nasal discharge with inferior turbinate hypertrophy. That may happen in even allergic rhinitis also. So that's why chest, the CT PNS was done. If you see, so the paranasal sinuses, they are opaque and there are some secretions which is visible inside them. Okay. Serial chest X-rays, if you see, there are hyperinflation in the X-rays. And so what is the other abnormality? Fantastic. That is a dextrocardia. So you got the clue. Recurrent nasal discharge, snoring, dextrocardia. What is the diagnosis? Fantastic. Catastrophal syndrome. And you have to show the CT also. There is no point in doing CT. So it was also confirmed genetically. Why genetically? Because you have to counsel the parent. You tell Katagener, they will not be able to spell it. They will get confused. So you want to show them that, okay, you have it. Last 2-3 slides. Diagnostic approach. So whenever a child is coming to you, non-severe bronchitis is after you exclude cystic fibrosis. But when the child is coming to you, you manage approach like a bronchitis. So how to approach? You take a very good history. Then you do you rule out first cystic fibrosis, PC, and inborn error of immunity. Okay, because infection you cannot rule out because infection is gone. So these are the second most common causes which you have to rule it out. Suppose you get it, treat appropriately. Suppose you don't get anything, you have to do the second line investigation. Suppose there is a child is having frequent choking episodes, recurrent hospitalization, or weight cup, and on X-ray there is a right-sided opacity. So that tells that probably the child is aspirating. Post-infectious, if it is active disease, then you can do. Otherwise, there is no point in doing because already the organisms are gone. Foreign body, do the bronchoscopy. Congenital abnormality, you want to see bronchoscopy, you have to do the CT. And this we don't see in our setting. So probably no need to worry for that. If you identify any etiology, you manage. If you don't, then send the patient to a center where more testing is done. And if you want, you can also send genetic testing. You may get some interesting diagnosis. So there are many conditions where, very difficult to spell also. So management multidisciplinary because I told it is an irreversible disease. So we have to involve like your department, pediatrics, then microbiology, then your physical, that is PMR, your physical medicine and rehabilitation department, okay, and the radiology department, okay, because these are very, very important. So you treat first the underlying cause. If you treat the cause, so sometimes bronchiectasis may be reversible because we don't know whether it is a irreversible or reversible stage. So there is no it is a kind of watershed area. So if you treat and it is reversing, that means probably it is not in the kind of irreversible stage. Okay. So then you have to educate the parents and the child. You have to explain them that it is a chronic disease. You have to be adherent to therapy. Some restrictions you have to follow. The child has to take annual influenza and pneumococcal vaccination. Any patient with chronic respiratory disease always give this annual influenza and pneumococcal vaccinations. Okay. And Airway clearance is the cornerstone of therapy. Why? Because if the secretion is there, that act as a milieu for infection to happen and infection will damage. So if you make the chest clear, what will happen? Infection will not be there. And if you are able to clear the infection, clear the airways, the life expectancy in non-CF bronchitis is very, very good. Patient we have seen like from the adult series, they may live up to 40-50 years also, which like, kind of it is okay. Mucolitis hyperosmolar therapy you can use like NST-assisted hyperosmolar therapy like your 3% saline. So what we do like 65 doses patient, you have to first give a bronchodilator. Why? Because this hypertonic saline causes bronchospasm. You nebulize with your salbutamol or levosalbutamol, then give 3% saline, then do the physiotherapy. So how many times you have to do the physiotherapy? That depends upon the amount of cough the child is producing. Suppose copious secretion, 3 to 4 times in 24 hours. Suppose no cough is coming. You ask the child to cough. In the follow-up, what we do, how to know that the cough, the child is having secretions inside the chest? You ask the child to cough. If there is no sound, probably the chest is dry. So if the chest is dry, they can do even once daily. So from 1 to 4, depending upon how much wet cough is there and how much secretions inside the chest you are expecting. Airway drug therapy, bronchodilator you have to give because most of the time these children will have this bronchospasm. So you have to give anti-inflammatory therapy because there is active airway inflammation. So we put these children on ICS, that is the inhaled corticosteroid, like that of asthma, and we ask them to take this salbutamol nebulization or inhalation MDI whenever there is exacerbation. So then azithromycin. So azithromycin, in CF we are routinely giving this azithromycin. So in non-CF bronchitis, some studies have shown that if you give daily azithromycin at a dose of 5 mg per kg per day, what will happen? It will prevent it will decrease the inflammation of the small airways. Mind it, this was a question in our 2004 All India entrance examination. Which of the following class of antibiotic is anti-inflammatory? It is only macrolide. So in bronchitis, in CF, you don't give it to decrease the risk of infection. Many patients think that or peripheral physician, they will think that you are giving to decrease the rate of infection. They will stop it. You tell them that azithromycin bracket, it is given to decrease the inflammation and disease progression. If you write that, they will not stop. Because many children we have seen that they will tell, why you are taking antibiotic? There will be antibiotic, they will teach antibiotic resistance, stewardship, this blah blah will happen, they will stop the antibiotic. But where it is required, they will not do. So that's why we write azithromycin, it is given for airway inflammation, not for treatment. Antibiotic therapy for exacerbation, the most common cause of exacerbation is the infection. So in all children with infection, what you have to do? You have to take the sputum, then do the gram stain culture. Suppose you are not getting anything. So what antibiotic to use? Based on your previous report. Okay, so what the child has grown previously. Suppose it is Pseudomonas, you are not getting anything, you give anti-pseudomonal cover. Suppose previously he has grown Staph aureus, now has not grown anything. Empirically, you can start anti-staphylococcal. So based on the previous report also, you can give antibiotics. Finally, surgical. Suppose hemoptysis is not controlled, uncontrolled. In that case, you may have to do some surgery. Suppose one lobe is totally bronchiectatic, it is causing recurrent infection. It may damage the other lungs. In localized bronchitis cases, what happens? The pediatric surgeons in our center, they do the pneumonectomy. So they will remove that portion. Or lobectomy if one lobe is affected. So what will happen? The other lungs will be spared actually, because if there is an infection in one side, it will percolate to other side and also damage. Finally, some key home messages. I think all of you must be breathing now. So after this extensive kind of this one. So recognition of chronic wet cough is of paramount importance. Adequate treatment of protracted bacterial bronchitis or chronic suppurative lung disease might prevent bronchitis. MDCT with HRCT to confirm bronchitis. So do not write HRCT. Think about the etiology. Whenever you are dealing, what happened? Why this child developed? Because in some cases, as I told, if you clear the etiology, bronchitis may be reversible. Chest physiotherapy is the cornerstone of management. That has to be adequate. And treatment of exacerbation is mainstay of therapy, because if you treat adequately, the survival of the patient will be higher. So with this, I conclude my talk. Hope all of you like this. So thank you so much again for the nice food and And I was scared of Dr. Sarika because whenever she will see me, have you tested this? Have you tested that? So yesterday we took that famous one of the, you can take kind of benchmark of this basket chart. So the basket was really good and I was able to finish. So thanks to me, I am a foodie. And the second, I took that tunde kebab. We have heard it but never had it. So yesterday the fellow and resident, they went with us, and in the night, still it was kind of, the traffic was not low, it was high traffic. We parked and we went. Tunde kebab was, it was amazing. So these are the, so thank you so much Dr. Sarika for the hospitality. And I told you keep something for the next visit, otherwise if I finish, I may not find it interesting to come to Lucknow. So there should be some reason actually. So thank you so much.
Thank you, Dr. Rashmi, for that extensive talk. It will be surely beneficial for our residents. Thank you. Now I would like to invite Dr. Nirmalya. So Dr. Nirmalya is currently Professor of Pediatric Oncology at TMH Mumbai. He has been extensively trained in pediatric oncology from here, from UK, and he has also a fellowship in pediatric oncology in BMT from London. He has more than 60 publications. His areas of research primarily are leukemia and lymphoma. Welcome, Dr. Nirmalya.
Thank you. So it's a pleasure to be back in Lucknow after 10 years. And double pleasure is to see Madam sitting in the audience. So when I came to Lucknow, I came to do a PhD, and my inclination was to go for immunology. But somehow Madam convinced me to stay in oncology, and no regrets. And the other realization that I had while doing my PhD was that, I wanted to do some lab work, and I thought that I'll become a scientist. But then, after working in the lab, doing all the wet lab procedures, I realized that it's not my forte. So I stayed back in the clinical side. But then, of course, the lab experience did provide me with an oversight of how things are happening in the lab. So that now I have got some studies where I collaborate with people in the lab, and then I'm in a better to understand what exactly they want to do. So that was it. Let me just go through the presentation brief. I'll try to be a bit brief and fast because I'm standing in between you and the lunch. So your residents are well fed, madam. I hope. Okay. So I chose this topic to just to avoid being too technical. So it's a more general talk on how pediatric cancer has evolved in our country, and how we care for our patients these days. What all new things have come in the last few years or so. So it's an update sort of presentation. So successful treatment of cancer in children, hinges around these three things: early and proper diagnosis, and of course proper treatment. I sit in Tata Memorial Hospital, Mumbai, so we see referrals from all over the country. Many a times we see patients who come very late to a hospital, not because they did not report to their doctor early, but because the diagnosis took a long time and people suspected a malignant condition after a long time, wasting a long time, and then they were referred to us. Of course, many patients come with wrong diagnosis. So early diagnosis and proper diagnosis are actually the cornerstones. And of course, once your diagnosis is made, it is actually easier to treat them, because now all the protocols that are used in pediatric oncology, wherever you treat a patient in the world, are quite standard. And people who are trained in whichever protocol would lead to a sort of commensurate outcome, regardless of where the protocol originates from. So these three things are important. So as in many other conditions, treatment of pediatric cancer is a multidisciplinary affair. You need the surgeons, the radiotherapists, and of course ourselves, we call ourselves pediatric medical oncologists. And of course, you need a robust diagnostic facility, molecular biologist to help you with finer details. And of course, there is no way to understate the role of nurses, dietitians, psychologists, and social worker in organizing the care. Without the whole team, your treatments are not going to be successful. So, of all the pediatric cancers, as you know, pediatric ALL is the most common one. Close to 30% of all pediatric cancers are acute lymphoblastic leukemias. And very happy to say that childhood ALL is also the poster boy for pediatric oncology. As you can see, the survival curves from sorry, is there a pointer? Red. Oh, this one. Right. As you can see on this survival curve from the St. Jude pediatric ALL cohort, the outcomes have improved significantly. And if you see, the lowermost curve is from the 1960s. So in a span of 70 years, 60 to 70 years, the outcomes have shot up to close to 100%, 95% almost in the current results. So this is the most successful story in the arena of pediatric oncology. However, it's not that other diseases we can't cure. So almost all the diseases have shown an uptick in the outcomes in the last many years. This is from the German cohort. You can see, you name any pediatric cancer which is common, and you see that all the outcomes have gone up in the last 30 or 40 years. Same trend again from the US CR data. They have reported an overall cure rate of 84%. 5-year survival rate, 84% for all cancers taken together in children, and of which ALL has inched towards 90% mark as well. So how did we arrive at this remarkable success from a nearly lethal disease in the 1950s or 60s? Now we are able to cure close to 90% of all our patients. So this has been mainly achieved by these things. What is important is to set up standard protocols. You can't treat each patient differently, so you have to have a protocol which you should follow to the T, I must say. And of course, it's important to know what is happening to your patients. You have to have a proper data collection mechanism and a registry, if possible, in the country or in the city where you're working. Unfortunately, we don't have a national cancer registry for children in India yet. Of course, with more advanced, sophisticated diagnosis, you are able to re-stratify patients better. So there was a time when all patients were treated with very intense chemotherapy because we wanted to just cure the leukemia. But in the process, we were losing some patients to toxicities, which even today we do. And a significant subset of patients were developing long-term toxicities. They would get cured of their cancer and would have survived for years together, only to develop long-term toxicities later in their lives when they're free from cancer. So taking all of this into consideration, people are now focusing on risk-stratified treatment. So a patient with a high biology risk, high-risk biology disease would receive more treatment. A patient who is having a low-risk biology would receive less treatment, so that the chances of losing them in the acute or them developing a chronic toxicity would be minimized. Of course, improvement in supportive care, more aggressive treatment of infections, ICU support, and all those things are absolutely essential when you are trying to deliver intensive chemotherapy to patients. And how do we know which protocol works best? The answer is that it's all the result of the large cooperative trials, mostly multinational trials as well, and of course multi-center national trials. For example, from the US, the COG group has done so many trials which has refined our knowledge of how to treat pediatric ALL. Similarly, the Europe it's a continent, but then there are so many countries who join hands to run a protocol, and then those protocols have also helped us to standardize our treatment. And of late, in the last decade or so, advancement in molecular diagnostics have helped us to find out the biology of the disease and target our treatment based on that. And of course, what is the most important thing in the last 5 years has been the advent of immunotherapy and small molecule inhibitors, which target the genetic aberration that the cancer has got and can effectively cure patients without much toxicity. So you can avoid using very intensive chemotherapy when you combine chemotherapy with this type of molecules like immunotherapy or the small molecule inhibitors. However, as with every disease, there is a disparity between the West and the lower middle income countries. And as you can see, there's a huge mismatch as regards to the caseload, the resources, and the cure rates in the developing countries. And on the right-hand side, you can see that the developed countries, the cases are less, the resources are probably infinite, and cure rates are really good, which is just the opposite in the LMIC countries. And unfortunately, the LMIC countries have got more than half of the caseloads the caseload that the world sees, I mean, in terms of pediatric cancers. So until recently, we knew that the annual incidence rate of pediatric cancers in our country is close to 50,000. But there has been a recent exercise which was published in 2021, where based on the cancer registries that are available locally, for example, Chennai has got a cancer registry, and so many other cities also have got, but we don't have a national yet. So they have found that probably 75,000 of our under 18 patients are developing cancer each year. So which is a significant, healthcare burden for our country. However, in India, we have lots of challenges. There's a heterogeneity of health delivery system in India without a sort of unification. So a child who is treated in a remote or a smaller city will probably not do as well as a child who is treated in a center of excellence in a metro city in India. So that deficit remains, which is, grossly contrasting from what we see in the developed countries, where every child in their geographical territory would receive the same standard treatment and all standard protocols will be followed across the country without any heterogeneity. Regardless of whether you are getting treated in a smaller city or a bigger city. There are a lot of competing priorities. We have infectious diseases and all those things which probably overtake pediatric cancer as the leading cause of morbidity and mortality in our children. So fund allocation also becomes a problem. And there are many national health programs which are rolled out targeting these infectious diseases, or for example, iron deficiency anemia or similar other things, but cancer is largely ignored in the government policies as well. And of course, a child who comes with cancer will have other comorbidities more often in our setup as compared to the West. You have multiple comorbidities like malnutrition and underlying infection, which prevents delivery of adequate therapy that you plan to deliver. And of course, there are socioeconomic challenges on the part of the patient and on the part of the center, which prevents us to deliver effective and uniform treatment all over the country. So the barriers to optimal outcome in childhood cancers in India can be classified mostly into two subheads. Barriers to access, which is mostly on the patient side. They have the families are not that literate, and this care-seeking behavior suffers as a result of illiteracy. Financial constraints to seek care promptly. Cultural barriers. We still see patients who have been to faith healers and non-conventional medical system, and as a result of which patients presenting very late to a cancer center. And of course, lack of cancer centers across the country is a big problem, which is gradually getting better over time. So which leads to late presentation and poor compliance to treatment as well. And on the side of delivery of care, we have got barriers. We have generic drugs without any quality control. So we get so many medicines which are priced at a much lower rate as compared to the innovator brands. But then there is no pharmacokinetic or pharmacodynamic studies done on those formulations to know whether they are effective. So that actually jeopardizes your treatment outcome. Insufficient manpower, poor infrastructure. That is there for most of the centers in India, because our need is so much, but our resources are very limited. Of course, presence of infections and malnutrition that I've already mentioned, and inadequate local research. This is an important point. See, most of the protocols that we have adopted are from the West, and most of us would just try to follow a Western protocol without trying to change anything based on our local circumstances, because we don't have enough data from our country to see how our children are doing on these protocols. So that actually can lead to excess toxicities in our patient. So this is an important thing, but over time, the situation is getting better. I'll come to that in a few slides from now. And yeah, so barriers to access and barriers to delivery of care. So apart from treatment is one part. The other part is to provide a holistic support to the child and the family when they undergo treatment for cancer, because cancer treatment can be intensive as well as prolonged. So they have to stay closer to the cancer center, and all those things are there. which would mean loss of pay for the parents and so many other things, social implications to the family and the patient and the parents as well. So what is important, we have seen in Tata Memorial Hospital that financial support, accommodation, nutrition, transfusion, availability of transfusions, psychosocial support to the family, transport to and fro the accommodation and the treatment center, education of the child, ongoing. See, most of the children are in the school when they get a diagnosis of cancer, which means that their schooling would get interrupted for a long period of time while they're getting treated. So this is something which is not desirable. So in our hospital, we have informal schooling that is available to our children. And of course, for children who need to stay for long duration and are reasonably okay to go to a public school, we have made an arrangement with some of our municipal corporation schools where our patients also visit, mainly those during maintenance and less intensive parts of the treatment. Yes, so this is just to say what has happened in Tata Memorial Hospital. This is not reflective of the whole country, but as I said, that the situation is getting better. So from 2000, in the year 2008, we lost a lot of patients because they were not able to afford treatment, or social circumstances and whatever, they would leave treatment midway. And gradually over time, by the end of 2018, our treatment loss or TR, treatment refusal or abandonment rate has come down significantly because of all the steps that were taken in a stepwise fashion over time. And a large part of this is being funded by the corporate social responsibilities. So it's very important that we raise funds for pediatric cancer, because even in Tata Memorial Hospital, we can't rely on government funds solely for the treatment of these patients. And it has shown a dramatic effect. If you see from 20+% of tRNA, treatment refusal and abandonment in the year 2008-9, our rates have come down to 3.6% in 2018 because of this support. However, not everything is gloomy, and over time there are many things that are changing, worldwide as well as in India in regards to pediatric cancers. And as you know, as I discussed, that multidisciplinary care is must for treatment of pediatric cancer. So you have to have a good radiologist, you have to have a good surgeon, a good radiotherapist who would deliver radiation in case it is needed, and of course effective systemic therapy to cure these patients. And most of these have actually evolved in the last decade or so. And I'm just going to highlight some of the things on these aspects actually. So if you know, this is retinoblastoma. This is the most common eye cancer in children. And we do see patients who come with this type of diseases. But then this is a difficult to treat cancer because chemotherapy is something which doesn't go much into the retina. So the retinal tumor is inaccessible to chemotherapy. So you'll have to target it from many aspects. Sometimes you give radiation, sometimes you give local therapy, you give chemotherapy within the eye. And of course, surgery is also there for patients who come with advanced disease. But now, with the development of interventional radiology, you can actually deliver chemotherapy to the tumor by selectively giving chemotherapy at a very high dose in the feeding vessels of the tumor. So this is called intra-arterial chemotherapy that is used, you put in a catheter guided by radiology into the ophthalmic artery so that so you can see the catheter. I don't know if it's visible from a distance, but then yeah, this is how the chemotherapy is delivered. So you give very high dose chemotherapy to these tumors, but if you give this high dose chemotherapy via vein, what will happen? The patient would die because of toxicity. You can't afford to give such high doses of chemotherapy, which is very effective to kill the tumor, but will kill the patient also because you're giving it systemically. Otherwise, you should give it locally just into the tumor, and this is how we do it. And this is a picture of an intraocular retinoblastoma. And if you see after 2 cycles of ophthalmic artery chemo infusions, the tumor has shrunk and it is barely visible actually. So this was about interventional radiology. Interventional radiology is very important when you are managing your patients with pediatric cancer. I don't know what are the services available here as regards to interventional radiology, but then this is important for diagnosis, this is important for treatment and management of complications as well. I'm not going to more detail because of lack of time. So then comes advances in surgery. I have just picked up this. So any tumor around the knee previously would lead to an amputation. But now with development of surgery, we have limb salvage surgery, which has been practiced in Tata Memorial Hospital for the last 20 years, thanks to Professor Ajay Puri, who was a pioneer in India regarding limb salvage surgery. And the functional outcomes are amazing. You can see this guy can actually flex his knee, and he's got all prosthetic implants with him. Coming to radiation therapy, so over time, radiation therapy has fallen into disrepute because it produces a lot of toxicities in children, most of which are long-term toxicities. Those long-term toxicities can be life-threatening, like a second malignancy, or lead to a lot of morbidities like neurodevelopmental problems, neuropsychiatric issues, and all those things. So which has led to elimination of radiotherapy for most of the pediatric cancers, namely the leukemias and lymphomas. However, for some conditions, we still need to give radiotherapy, which is mostly for the solid tumors or the brain tumors. But then now we have more precise ways of delivering radiotherapy so that the long-term toxicities can be minimized. So how many of you have heard about proton therapy? So proton therapy is a very new and unique way of delivering radiotherapy to a patient. Because it targets the tumor in a very accurate way, and it doesn't exit out from the body. So the conventional radiotherapy, if you see, so once the tumor is irradiated, the radiation dose will go out of the body from the other end of the body. So effectively irradiating the whole thing that comes into its field. Whereas proton therapy, there is no exit dose. So the tumor, the radiation hits the tumor, and that's it. It dies down. So this has led to improvement in long-term toxicities of radiotherapy. And as you can see, the clinical implications. So this is a child who was getting a spinal radiation. And you see spinal radiation using photons photons means conventional radiotherapy, by the way, would radiate the spine, as well as it will go to the chest as well, the front of the chest. And you can see the degree of exposure. So the intended volume was this, but then the radiation has come to the heart and to a part of the lung as well, which can lead to long-term morbidities as regards to cardiac and pulmonary function in these patients. But now with protons, you see the radiation is limited to the area, the target area of interest. It doesn't spill over. And of course, in terms of systemic therapy, there have been lots of advances, mainly driven by molecular discoveries. So scientists have been discovering new targets in each cancer, and the drug discovery people are developing molecules which can target all those genetic aberrations. So which has actually revolutionized the treatment of pediatric cancer, at least for some forms of pediatric cancer, in the last 1 decade or so. And as you can see, molecular classification helps us to tell which patients would need more treatment. And we are now using something called as MRD, which is called measurable residual disease, which is a marker of treatment response. And based on MRD, if you stratify patients, you effectively avoid very intensive treatment to patients who are otherwise good risk. Targeted therapies, as I mentioned, small molecule targets like tyrosine kinase inhibitors, for example, imatinib or any of the other tyrosine kinase inhibitors are used in CML and PH like AL or PH positive ALLs. Even in sarcomas, we are using targeted agents these days. Though not, as a part of routine standard clinical care yet. Antibody-based therapies have been useful, and targeting these surface antigens in the leukemia and the tumor cells. And some of them have actually come to the frontline therapy as well. For example, rituximab. How many of you have heard of rituximab? No one? So this is something which has come to the frontline management of NHL. So there are so many other antibody-based treatments. And immunotherapy, yes, immunotherapy is also important. For example, CAR T cells, which is a big thing in today's day, and checkpoint inhibitors. They have actually helped us in improving the outcomes a lot. So this is a slide on how advent of imatinib has changed the outcome of CML. This is adult data. So initially, before advent of imatinib, the chronic phase outcomes would be around 40%, but now with imatinib, see how it's close to 100%. So similarly, If you target molecular aberrations in brainstem gliomas, for example, in this child with a low-grade glioma, you see at diagnosis this was a size. With some chemotherapy, the size hadn't decreased, rather it had actually progressed a bit. But with a targeted agent against BRAF is a mutation. Let me not go into detail, but then BRAF inhibitors can actually work wonders. As you can see, the tumor has shrunk to less than half of its size within 2 months of initiating this treatment. But the star of the show, at least for today, is CAR T cells. How many of you have heard of CAR T cells? Yes. So the patient's own T cells are engineered to fight the leukemia cells. So the T cells are taken out of the body, engineered with a viral vector using this CRISPR-Cas9 technology, which got Nobel Prize, I think, 2 years ago. And thus you produce T cells which actually can fight back the leukemia. So they're put back into the patient, and as a result, the patients respond well. So in the year 2012, there was a case report of Emma Whitehead. She was the first survivor after receiving CAR T cells, despite failing 2-3 lines of chemotherapy and transplant. So from that time onwards, it became a very important discovery. It was made in Children's Hospital of Philadelphia, CHOP, in the US. And Novartis came into picture after this report. And then you can see this Forbes magazine headline. This man was a Novartis CEO, and it was asked whether this man will cure cancer. So based on this report and afterwards many other phase 1 and phase 2 studies, the FDA approved CAR T cells in the year 2017 for treatment of pediatric ALL. And in India, our center had collaborated with IIT Bombay under the knowledge guidance of NIH in the US to develop the first domestically produced, completely domestically engineered CAR T cells. And if you see the timelines, it all started in the year 2015. By 2019, we got approval to conduct early phase trials in our patients. By 2020, last year, 2023, it got approved for adult use, because adult approvals come faster than children, because children are a vulnerable population. We are currently running a phase 2 study in children, and we hope that this will also get approved by DCGI for use in pediatric ALL in our country. So CAR T cell therapy has developed in India, in Bombay, but then there are a couple of other centers, one in Delhi and one in Bangalore, which are using CAR T cells, which are imported from the West, leading to a high cost. What is also important to see is to see all the BMT centers that provide bone marrow transplantation services in India. Though these seem a lot, but I must tell you, less than 10% of our patients who need bone marrow transplant in India are getting transplanted because of lack of facilities. This is actually some animation mode. So these are the 3 centers which are using CAR T. So our center, which is using a homemade CAR T, but then these people are using CAR Ts that are imported from the US and Europe. However, is CAR T going to be the solution for all leukemias, or for that matter any other cancers as well? No, not really. So Indian roads are not made for Audis and Mercedes and all that. So we also need to have bullock carts, in the traffic. But then what is important is to know about these recent developments, but at the same time stick to your existing protocols. Try and execute them as much as you can. And of course, in some time, these things will become accessible to patients, the hi-fi treatments. But the picture is not so rosy, as I was just telling that. Though we have our first homemade CAR T in our center, we have got access to antibody-based therapy since 2021. We did a small audit last year and found that 90% of our patients who need these advanced therapeutic options are not getting in our center itself, because the need is so much, the solution is too little. The availability is too little. So what is important is to find out a way to reach the last child in the queue. So that is the most important thing. That's the public health concern. And I must say that over the last couple of decades, there has been considerable progress in this. I'm not saying that we are there yet, But then, if you can see, the National Cancer Grid was founded in 2012 or 14, I think. Now they have got 300 plus cancer centers. So what does National Cancer Grid do? So they actually aim to provide uniform high quality cancer care to every citizen in the country, regardless of where they are staying and how they are doing economically. So the main aims are to generate consensus treatment guidelines, to have institutional peer review of the treatment procedures that are being done, to have standardized pathology, to provide palliative care upgradation for centers. Palliative care is important, which we ignore a lot. And of course, connect with physicians for second opinions and all that through virtual tumor boards and other online second opinion services. So we have a national virtual tumor board. I think Dr. Nishant is aware of this. So, I mean, if you have any difficult case to discuss, you can communicate with us, and every month we hold one. And there are other many specialties where they hold these virtual tumor boards under the aegis of Tata Memorial Center. We have got a sort of second opinion service where patients don't need to travel to Mumbai only for the sake of second opinion. They can get it online and at a very affordable cost. I think some 2,000 rupees, but for BPL patients it's free of cost. Our Tata Memorial Center has expanded a lot in the last few years. So in Mumbai, we have got 3 sites. We have got sites in so-called underserved areas of the country like Varanasi. We have one in Sangrur in Punjab. We have one in the northeast, which is Guwahati. There is one in Visakhapatnam and Chandigarh as well. I mean, you won't be surprised to know that the most populous hospital in this group remains, I mean, Mumbai remains to be the most populous one, but Varanasi is picking up a lot. So that is the second highest recruiting center of our group. So, I mean, sometime previously, our previous director had envisioned that probably Varanasi will overtake TMH Mumbai, because it will actually cater to most of the underserved areas of the country. Ayushman Bharat, I think you are aware, so 5 lakhs per patient they would provide, and I mean, you can actually have a live account and not pay from the pocket, or there is a scheme to get things settled and reimbursed later as well. So as I was talking about generic drugs, yes, generic drugs have helped us a lot, because you know, there is a patent law which prevents use of generic versions for quite a few years after the innovator molecule is approved. But in India, the things are different. There was a Supreme Court judgment that you must have heard, and which led to an editorial in the NEJM in 2013, which said that India is the world's producer of generic molecules because our regulations were not that bad. However, and of course, there is drug price control in India. I mean, the generic things cannot price themselves over and above a limit set by the government. This is a double-edged sword. It makes things available and affordable to people who can't afford, but at the same time, it's actually taking away all the leading manufacturers away from the market, because they can't produce things which are price regulated and are very cheap, because they lose their profit margin to such an extent that sometimes those molecules or those preparations become non-profitable. Even they run in loss. So this is a double-edged sword, but then we have to strike a fine balance sooner or later. The last thing that I want to touch upon is collaborative research. You know, research matters a lot. So you can read the heading of this slide. It says that collaborative research matters because they benefit future patients. So when a patient is taken into a clinical research study, it's most of it's told that this study might not help your child that way, because there is a randomization. We don't know which arm works better. But then once the study is published, this is going to help future patients. And sometimes parents buy this argument, you know, I mean, when it comes to participating in a study. And as you can see, the WHO Global Initiative for Childhood Cancer also prioritizes investment in cancer research infrastructure and participation in collaborative research networks as one of its high priority actions. So there are so many cooperative clinical trial groups all over the world, and HICs means high income countries. You can see groups from the UK, from US, from the Nordic countries, Italy, Germany, and all those places. However, there are quite a few from the low middle income countries as well. I want to highlight about INFOG. You heard Dr. Nishant is a member of INFOG as well. So this is the Indian Pediatric Hematology Oncology Group, which was constituted in the last decade, and till now we have got 43 member institutions all over the country. And it's a pleasant thing to know that since 2015, close to 13,000 children with cancer and blood disorders, both benign blood disorders and malignant ones as well, have been enrolled in 24 clinical trials in our country, with close to 60% of our patients being in observational studies, just following up what happens to them, and close to a third of our patients registering actually in an interventional study, which is what we want, in 122 different institutions all over the country. And probably the poster boy of this, Indian collaborative studies is ICICLE. So this is a study that was for the first time that could rope in major treatment centers in India to pilot a common protocol for treatment of pediatric ALL, which happens to be the commonest pediatric cancer. And you can see, it's difficult to see from a distance, but then close to 1,600 patients were randomized in this study, and you will be surprised to see the outcomes. So the overall survival in 3 years of pediatric ALL based on the ICICLE 14 results are close to 86% and 70% of event-free survival. I hope you know what is overall survival and event-free survival. This is something that you should know if you don't know, but I'm not going to teach you now. So this is unpublished, but then it says, it clearly shows you the dividends of participating in a multi-center collaborative trial, which is controlled by one agency full of experts, and then you have all these data monitoring units and all those things which tell you that what is going wrong. And based on the wonderful success of the ICICLE 2014 study, the results have only come in the last 1 year or so. The ICMR has now asked the ICICLE group to pilot this protocol across 21 centers in the country. So initially ICICLE 2014 study was in 5 centers, and now they want it to be piloted in 21 spoke centers. No randomization, only the best arm would be used for treatment in these 21 spoke centers. It's a hub and spoke model of cancer care. It's called ISCAL, and ICMR has committed a budget of 25 crores for this, which is a big thing. They say that we are not going to fund treatment. We are not going to fund any machinery or gadgets or high-end investigation stuff for the hospitals. They only want to do capacity building by means of training people and making people familiar with protocols that are to be followed to the T. So by doing these simple things, you can actually improve the outcome in such a complex disease like pediatric ALL. So this actually aims to cover most of the country, and Tata Memorial Hospital is also a hub center. We were a part of the ICICLE 2014 study as well, and now we have got 4 centers in the peripheral areas which we mentor so that they are able to follow the protocol. And because ICICLE 14 is over, we have now envisioned the successor study, which is called ICICLE 2024. And ICMR, in collaboration with National Cancer Grid, has committed some 8 crores to this study as well, again in the previous 5 centers which were in the ICICLE 2014 study. And we plan to enroll very soon. Though it says 15th October, it has not started yet. In any time actually it will start. We have got all the regulatory approvals, and staff recruitment is ongoing in most of the centers. And coming to the last slide, I think the penultimate slide. So how about pediatric oncology training in India? So pediatric oncology is a relatively new specialty. Not as new as pediatric pulmonology or pediatric immunology, but as a specialty, it developed much after neonatology. But now we have an established training program, and as you can see, there are 80 fellows graduating per year in the whole country. These comprise of DM, post-DM residents who cleared their DM exams. And previously there used to be a 2-year FNB, which is now being converted by the National Board into a 3-year Doctorate of National Board, DRNB, which will also be considered equivalent to DM. So this is another thing that people can do to become a pediatric oncologist. And there are fellowships by the Indian Academy of Pediatrics, Pediatric Hem-Onc chapter, which is now going to be run by the Indian College of Paediatrics, right? And apart from that, there are numerous institutional and university fellowships, and there are some subspecialty fellowships available as well, like fellowships in transplant or fellowship in neuro-oncology. So there are a lot of things happening in the field of pediatric oncology, and I mean it's an exciting branch. So I would encourage you people to consider this as your careers. So take-home messages, I won't go through the whole slide again. Same thing, outcome has improved over the last few years, much better in the West as compared to what we see here. But then our situation is also gradually getting better. So last two slides on my time in Lucknow. So I was here in between 2011 and 2014, so 3 years. And these are the places that I used to visit commonly. So this is Paediatrics KGMU. I used to recruit the patients from here, run the lab studies in Sanjay Gandhi PGI. And this is the team that was there at the time. I think the last year of my posting here. Dr. Nishant has also joined, Madam again in the center. And we have all these research staff and myself here. And for who you can't identify this temple, this is a Ramakrishna Mutt. I used to be a frequenter of this place during my stay in Lucknow. Let's not discuss that. And then, I mean, Madam's guidance was so good that my PhD thesis, I could get a chance to present in the International Society of Pediatric Oncology meeting in Toronto in the year 2014. And I got an award of 1,000 euros. You can see the SIOP president with me holding the award certificate. And here you can see myself and Madam standing in front of a poster on abandonment in pediatric care, I think in the same conference. And this is me working outside Madam's office that is just across this corridor. Thank you so much.
Thank you, Dr. Nirmalya, and thank you for taking us down the memory lane. So with this, we come to an end to a beautiful academic session. So now I would invite all of you to join us for lunch. The residents and the staff are welcome to take the lunch in room 106 at Kalam Center, and faculty can join us in HOD. Thank you all.
हमारे भी सीजन से इसलिए हम बाहर ज्यादा मैंने बस फोटो लेना है ना अच्छा कम ये टेबल है संजीव ये टेबल हटवा दिया
ये संजय रख रहे हैं बैठे निकाल के